Vibhor, can you please change the name of Sony, Dr. Rajiv, to Dr. Rajiv?
Sony sir, Dr. Rajiv.
Yes.
Yes, great. Sir, we can start.
Good evening, everyone. I welcome you all for Cardiogenic Shock Symposium Part 2. Cardiogenic Shock Symposium Part 1 we did in 2019. And after that, there was a pandemic which set in, and definitely the academics has taken a backstage during this pandemic. And that is because the entire medical fraternity was taking care of sick patients either directly or indirectly. So cardiogenic shock is a very complex scenario, and it is a disease which is I would say syndrome which is not only related to the cardiologist, but it involves a multidisciplinary approach involving an ER physician, a primary care physician, an intensivist, cardiologist, cardiac surgeon, nephrologist, and definitely a rehab specialist. So the idea behind today's agenda is to actually gain more insight into the management of cardiogenic shock, which will help us to deliver better patient care, and we all can try to improve our patient outcome. So I think without wasting any further time, we should start directly with the symposium. And the first speaker is Dr. Dinesh Chaudhary. Dr. Dinesh Chaudhary is a professor of cardiology at SPM Medical College, Bikaner. He has done his DM cardiology and his fellowship in electrophysiology from prestigious Sri Chitra Institute of Cardiology, Trivandrum, Thiruvananthapuram. And Dr. Dinesh is going to talk about definition, classification, and hemodynamics of cardiogenic shock. First of all, I would like to thank all the chairpersons and speakers who have taken time on this weekend evening and agreed to participate in the Cardiogenic Shock Symposium. So Dr. Dinesh, enlighten us about your topic. Over to you.
Yeah. Hi to everybody. So I am sharing the screen. So is it visible to all?
Yes.
So we are going to discuss today the cardiogenic shock, why we need the new classification, what is the new classification, and what is the hemodynamics involved. Then we will discuss the practical utility and take-home message. So cardiogenic shock is a part of the syndromic classification of Subin shock classification, among which others are hypovolemic, obstructive, and distributive shocks. Everybody knows. So cardiogenic shock from last 20 to 30 years having same mortality, around 50%, 30% mortality, despite the usage of IABP, left ventricular assist devices, Impella, ECMOs, etc. There are so many trials which used to define the cardiogenic shock differently, but the shock trial came in 1999, defined the cardiogenic shock with systolic blood pressure of less than 90 or more than 30 minutes, or vasopressor support to maintain this BP, with evidence of end organ damage that we can define as urinary output less than 30 ml per hour or pool extremities. And obviously hemodynamics with cardiac index less than 2.2 and wedge pressures more than 15 millimeter Hg. Other trials also defined, but more or less this is the same definitions which most of the trials used. So why we need new? Because these patients are having a heterogeneous populations Prognosis vary widely based on etiology, severity of illness, and comorbidities. And spectrum ranges from cardiogenic shock due to isolated MI to critically ill patients with modes and hemodynamic collapse with cardiac arrest. There are so many scores which can identify the prognosis, risk stratifications like Apache 2 and others in cardiogenic shock, but no scores give meaningful characterization of the severity that can be easily communicated between providers and inform treatment and transfer decisions. Prior studies have failed to determine the effects that overall illness severity may have on the risk-benefit profile of available therapeutic interventions. Then this Intermax classification of cardiogenic shock came with staging of crash and burn, sliding on inotropes, dependent stability, and then there is support modifier, temporary circulatory support modifier. Then why new? Because these Intermax classifications or profiles all are intended for application at the single time point of implantation of a durable mechanical circulatory support device and do not have a construct to assess deterioration of status. So a more granular classification is needed. The new classification should be very simple. It should be suitable for rapid assessment. It should be applicable to retrospective data sets or prior trials, should have multidisciplinary applicability, and it should be usable across all the clinical settings, including emergency departments, ICU, cath labs, and others. In other words, the different subgroups should reflect different morbidity or mortality rankings. So this Sky given this classification in 2019 with multidisciplinary units involved: intervention cardiologists, heart failure units, critical care, emergency medicine people, critical care, and cardiac surgeons also. They gave the 5 stages A, B, C, D, E. A is at risk, B for beginning of the cardiogenic shock, C is classical shock, which we are usually discussing, then deteriorating and extremes of the shock. So step by step, we will see what is the physical findings of these stages, what are the diagnostics which we can use in these stages, and what is the hemodynamics. So stage A is at risk, means you are having the substrate, but shock is still not there. These patients may include those with NSTEMI, STEMI, acute or chronic heart failure. Physical examinations, nothing remarkable, labs normal, hemodynamics normal. Then the beginning, stage B is the beginning. A patient who is having clinical evidence of relative hypotension or tachycardia, but without hypoperfusion. They may have elevated JVP and rails in the lung fields, but patient will be warm and well perfused with strong distal pulsation and normal mentation. Biochemistry, normal lactate, normal renal function, but BNP may be raised. Cardiac index will be more than 2.2 and pH saturation will be more than 65. Then this comes classical shock. A patient with hypoperfusion that requires interventions to restore perfusion. Interventions can be inotropes, pressure agents, or circulatory support devices. And these patients typically will be having relative hypotension. They will be looking unwell, panic, ascent. Rails will be there, more than 3/4 of the lung fields, may require BiPAP or mechanical ventilations. Peripheries will be cold and claming, and urine output will be less. Lactate, usually lactate we are using for defining tissue hypoperfusion. If it is more than 2, mortality chances are on higher side. And then hemodynamics comes. Definitely there will be reduction in cardiac index. Pulmonary capillary wedge pressures will be going more than 15. Nowadays, different trials are using these 2 hemodynamic index, PAPI and CPO. So PAPI is pulmonary artery pulsatility index that defines right-sided functions, pulmonary capacitance, pulmonary artery pulse pressure divided by right atrial pressures. If it is less than 1.85, mortality chances are on higher side. and then this is cardiac power output. That is defined as cardiac output into mean arterial pressure upon 481. If it is less than 0.6, mortality chances are on higher side. This CPO is main measure which defines left ventricular contractility. Nowadays, the shock trials are using these two things for left and right sided heart functions. The stage D is deteriorating. Everything will be like stage 3, but these patients will not be having any improvement despite inotropic supports, and we have to require multiple pressures or addition of circulatory support to maintain perfusion. The last phase is phase E. Patient will be having cardiac arrest with ongoing CPR or extracorporeal circulatory support, or these patients will be having support of multiple interventions. Cardiac collapse will be there, patient will be on mechanical ventilation. If there is VTVF, patient will be multiple time defibrillating, and lactate will be going very high, more than 5 with arterial pH of less than 7.2. No BP will be there without CPR. There can be pulseless activity or refractory VTVF. So these are the 5 stages with hemodynamics in the new classification. With these 3 domains, we have to classify these stages with physical findings, biochemistry, and hemodynamics. This is the overall chart we have already discussed. Then there comes cardiac arrest, the risk modifier. Any cardiac arrest, however brief, will be defining the stages, like if patient is in stage B with cardiac arrest or successfully defibrillated VF will be defined as BA. If signs of hypoperfusion develops, that will be sliding to class CA. And if anything is not working, then that will be deteriorating. So cardiac arrest and cardiogenic shock frequently occur together, and prognosis for the patient with both is worse than the presence of the single one. That for recovery, there are 2 key components: presence or absence of neurological recovery or return of spontaneous circulation. So this is the overall hemodynamics. Classical cardiogenic shock patients will be having wet and cold. We have already discussed. Nowadays, there are so much debate on PA catheter use, but so many trials, and recently ESCAPE trial was there, in which it was found that there was no benefit of pulmonary artery catheter and was stopped early due to safety concerns. There were so many infections, there were so many ICD firings, and mortality was much more. Use of PA catheter is recommended to diagnose and or manage patients with cardiogenic shock, along with consideration of rapid transfer to experienced shock centers in the case of patients who require a higher level of care. So what is the practical utility of this shock classification? This new schema is totally arbitrary and fairly simple. It is applicable across the care spectrum. Prognostic and therapeutic merits of the proposed classification are expected to retrospectively and possibly prospectively validated. Patients with CS often having dynamic clinical symptomatology and hemodynamics. A patient can start at stage BA and then may worsen over the higher stage. This we can discuss with one example. See, if one patient, 60-year-old male with diabetes, hypertension, dyslipidemia, and tobacco use, and underwent CABG 10 years prior. So all having this at-risk patients, having substrate in the night, he develops PROPT positive ACS with low BP, with tachycardia, and he is scheduled for cath. At present time, the patient will be defined as stage B. Later that in the day, more tachycardia with cardiac index less than 1.8 and wedge pressure is going up, then the patient will be defined in the stage C. If anytime the patient having VF or VT defibrillated, then the modifier of the arrest stage CA will be added. Then the patient having low dose inotropic start, but patient is still deteriorating. IFBP also inserted, but there is continuous decline of the urine output and other parameters. Then the patient will be defined in the stage DA. And these worsening stages tells us that we have to escalate our support system and the mortality is on higher side. So we can conclude that mortality is more than 50%. If we are using common classification all over the world, we hope to communicate at the bedside, in the cath lab, at the level of SOAP team across institutions and with clinical trialists as new approaches to reduce the high mortality of cardiogenic shock. So what is the take-home message? Present, publish, and spread the word to the wider cardiovascular and critical care communities. Validate the classifications by evaluating its prognostic power and ease of use in databases. Drive earlier recognition of shock and more precise stages to guide appropriate and timely escalation of care, including transfers to center more fully equipped. Utilize the stages to better define prospectively the value of circulatory support or ECMO and other therapies. Perhaps future trials looking at similar patients will finally reduce the mortality of cardiogenic shock. And this classification was used in the trial later in 2019 at the Mayo Clinic, and they found that from 2007 to 2015, among 10,000 patients, they found that from stage A to stage E, there were patients 46%, 30%, 15%, 7%, and 1%. As the stage worsening, the percentage of the patients is declining, but mortality is increasing from 3% in stage A to 40% to stage D and 67% in stage D. So they have assessed this classifications in defining the mortality. And once the patients were having cardiac arrest, the mortality was on higher side in each stage. So what you can do, you can make a daily checklist for your patients. I have written here, and you can daily check the parameters, biochemistry, and if possible, hemodynamics, so that you can find out the patient is improving or deteriorating and better explain the patient's relatives. What we can do, we can also plan hub and spoke care model like trauma and primary PCI, so that we can have one multidisciplinary team at a higher side, and the attached hospitals can follow the detailed cardiogenic shock management according to that team and can transfer the patient according to this schema as early as possible so that we can save most of the lives. Thanks.
Thank you, Dr. Dinesh, for that excellent talk. And let me tell you, this is a very useful lecture, because once we start adopting the new classification, we all start speaking the same language. And you have clearly highlighted the importance of use of this new classification. And I believe this will also help us to escalate or de-escalate the therapy of a patient in cardiogenic shock as the patient moves up and down from A to E. And also your last chart, daily checklist, I think what you can do is you can email to all of us, and it can be very useful for management of a cardiogenic shock. We can have a very small discussion. Let me ask this question to Dr. Suresh Rao sir, if he is there, and then to Dr. Kailash, who's from Italy. Do you label cardiogenic shock? Do you label cardiogenic shock in the emergency? If a patient comes to the emergency and there are certain parameters which match the criteria of cardiogenic shock, is the patient labeled as cardiogenic shock in the ER itself, or is it labeled if the patient reaches to the ICU? Dr. Suresh sir?
Yeah, I think we follow that rush protocol. In the casualty itself, we will assess the pump function, we'll rule out all the reasons for the causes for the cardiogenic or shock. Basically, we look at the aorta dissection, pulmonary embolism, or deep vein thrombosis, and also send an ECG, echocardiogram, LV function. So usually it is diagnosed in the emergency itself, so that the relevant consultations can be taken immediately and immediate action can be taken.
Raji sir, are you there? Dr. Rajiv Bagrata sir is a professor and head of Department of Cardiology at SMS Medical College.
Hello.
Hello, sir.
Anji. Yeah.
Thank you for joining, sir. What do you think about, should we strictly implement this new classification in our clinical practice? And do you feel that labeling a patient as cardiogenic shock in the ER itself will help in better management as the patient moves to the CCU or to the ward?
I think yes, why not? Because the point is that, as Dr. Dinesh has already emphasized, that we should be on the common page while we are dealing with such sick patients. And the advantage of such classification is, if you are able to do so in the ER, that what we want to say in so many words can be said in single word when classify a patient according to, say, if the patient is A, B, C, or D. So yeah, I mean, we do try to make the diagnosis of the patient being in cardiac shock in ER itself, and alert the team waiting in the ward or in the ICU or in the cath lab accordingly.
Yes, so those were good inputs, and take-home message from my side is just one message that, you know, even if a patient is on NORAD and blood pressure is 110, it should be labeled as cardiogenic shock. What we hear from our ER colleagues sometimes, no, blood pressure patient is stable, and then you find out that blood pressure is 110 on 10 of NORAD and heart rate of 110, we should still call that patient in cardiogenic shock. So I think we move on to the next talk, which is a very important topic. It is cardiorenal syndrome. A patient who is in cardiogenic shock or who had multiple cardiac problems, kidneys play an important role. And in I would just use a layman term here, that what we see in our ICU, if a renal shutdown happens, then we kind of, we get disheartened and we feel that this patient, might not do well. So let us hear from Dr. Ajay Singh. Dr. Ajay Singh is head of nephrology at RHL, and he did his MD and DM, MD from PGI Chandigarh and DM nephrology from SGPGI Lucknow. He has vast experience of treating patients with end-stage renal disease and also patients with renal transplant. Ajay is going to educate us about treatment of cardiorenal syndrome in cardiogenic shock. Number one is how to diagnose, how to identify, and its management. Dr. Ajay, over to you.
Good evening, everyone. First of all, I would like to thank Dr. Ravinder Singh Rao and the organizing team for giving me this opportunity to interact with you all. I hope this slide is visible.
Yes, Ajay, we can see your slides.
Okay.
You can do a screen share first.
Yeah, I have shared the screen.
And go to the presentation mode. Live, click on play. Click on play.
Just a second.
You can see play on the yes.
Yeah. Okay, so let us start with the presentation. We all know cardiorenal syndrome is basically a pathophysiological disorder involving the heart and the kidneys, where acute or chronic dysfunction of one of them affects the organ or another organ and leads to the acute or chronic dysfunction in that organ. And in the starting, cardiorenal syndrome was basically seen as acute or chronic cardiac dysfunction affecting the kidneys. Slowly, it was realized that both the organs interact with each other, and it is also equally true the other way around. The renal diseases affecting the pathophysiology and bringing out the changes in the heart. And formally in 2008, acute dialysis quality initiative consensus reached to that, and they basically divided the cardiorenal syndrome into broad phenotypes involving cardiorenal or renocardiac syndrome, depending on which organ is affected first. Although it is not always that easy to differentiate which organ was involved first, especially when the patients present late. As far as cardiogenic shock and AKI is concerned, it is strictly time dependent, because the longer they persist, the higher the chances that the damage which they are causing to each other is going to become an irreversible organ damage. So if we see the classification of the cardiorenal syndrome, the initial two, type 1 and type 2, basically represents the cardiorenal part, where the primary organ involved is the cardiac, and acute or chronic cardiac dysfunction leads us causes changes in the kidneys and leads to acute kidney injury or a chronic renal dysfunction. Type 3 and 4 basically represents the renocardiac part of cardiorenal syndrome, where basically kidneys are at fault and they causes changes in the heart and leading to heart failures or a left ventricular hypertrophy and changes. Type 5 is called secondary cardiorenal syndrome, in which basically a systemic process involving both the kidneys and the heart. Today, we are going to focus only on the type 1 cardiorenal syndrome. Type 1 cardiorenal syndrome also has two set of patients. Those more commonly seen are those presenting with acute heart failure and acute kidney injury. But today we will be focusing on the more severe form of type 1 cardiorenal syndrome, that is patients who are in cardiogenic shock and presenting with acute kidney injury. So acute kidney injury can be simply defined as any acute decline in renal functioning occurring over a few hours to few days. And officially it is defined as a rise in serum creatinine of 0.3 milligram per deciliter or more over 48 hours, or a 1.5-fold increase in creatinine happening in a duration of less than 7 days. So initially severity of acute kidney injury was defined by rifle criteria. Then it was defined by the acute kidney injury network. In 2012, what KDIGO did was they picked up good things from both the classification and then they clubbed them together. And it is basically defined on the basis of creatinine and urine output or estimated GFR, which is generally calculated from the creatinine. So any rise in creatinine up to 1.5-fold increase is taken as stage 1, more than 2-fold increase in stage 2, and more than 3-fold increase in stage 3, or if the total creatinine goes above 4. Similarly, urine output criteria are there, but all those these criteria are not equal. It has been observed that patients in whom severity of acute kidney injury is defined on the basis of creatinine, it correlates well with the survival probability and the mortality outcomes. And it is similar with the cystatin C. And AKI criteria correlates well whether we divide them on the basis of creatinine or cystatin C. But when we use urine output as the criteria, then it is felt that we are more liberally classifying those patients in acute kidney injury when they actually may not be having a significant renal involvement. So the first criteria, as per the urine output, that is less than 0.5 ml per kg per hour for 6 hours, those patients and those patients who never had an AKI, they had almost similar outcome. So maybe a stricter urine output criteria will correlates better with the actual outcomes of the patients. So for cardiogenic shock, we can summarize that it is for kidneys sort of sum of all evils. Because you can see it involves kidney from multiple perspectives. There is an acute myocardial dysfunction. There is a hypotension despite elevated left ventricular filling pressure. There can be an involvement of the right ventricles. Most of these patients will need some sort of pressure supports causing vasoconstrictions. They may need a PCI involving a dye or a cardiac surgery, as most common cause for this type of cardiogenic shock will be a ischemic event and an iatrogenic or IABP. If we look in the detail of the pathophysiology of the cardiorenal syndrome, we can see that there is an initial and acute cardiac insult leading on to a reduced cardiac output, leading to a reduced effective arterial volume blood circulation, reduced renal blood flow to the kidneys. At the same time, many of these patients will be having high venous pressure, and which will cause venous congestion, interstitial edema in the kidney, and again will reduce the perfusion pressure. Recently, more and more emphasis has been focused on this part of the increased venous pressure, but more in connection with acute heart failure. In cardiogenic shock, the cardiac output part is also equally important. Other than that, the body tries to maintain the blood pressure. There is a surge in sympathetic nervous system activity. There are increased renin-angiotensin aldosterone system is hyperactive. all of these together lead to initially kidneys are able to maintain their filtration fraction with the help of these physiological changes which are occurring. And if the cardiogenic shock is corrected at this stage, then kidneys continue to do well. But if the shock persists or worsens, then this physiological change actually goes on and become a pathological event, and the compensation mechanism fails and the GFR starts to decline, and kidney injury happens. If we see acute kidney injury is not just one of the consequences of cardiogenic shock, it in itself brings along with it lots of deleterious systemic effects. Other than its effects on heart in terms of salt, sodium, and water retention, increased chances of peripheral edema, pulmonary edema, electrolyte imbalances, acid-base imbalances. Acute kidney injury has also effects on neurological outcomes, on lung functions, on GI system producing more of intestinal edema and reducing their function, thereby further complicating the cardiogenic shock. If we see the epidemiology of this AKI complicating cardiogenic shock syndrome, then AKI is quite common, and it can be seen in range from 20 to 35%, varying from study to study depending on the inclusion criteria and the time point at which the AKI is being captured. But it is a common trend. We see in all the studies that the patients who have acute kidney injury, they generally have higher rates of in-hospital complications, higher morbidity, mortality, higher length of stay, more economic burden, and poorer outcomes. In the acute kidney injury also, the severity of the renal dysfunction correlates with the outcomes. So more severe the injury, worse the outcomes. So especially patients, those who require renal replacement therapy, that constitutes around 6 to 10% of the total cardiogenic shock patients, actually fare worse than the rest of the patients. So this is a study showing the incidence of AKI in ST elevation MI cardiogenic shock. We can see if we capture the data at 24 hours, around 27% of the patients were having AKI, but when the same data was captured at 72 hours, almost 50% of the patients were having acute kidney injury. And this acute kidney injury does not only have a short-term effect, it has a long-term effect. Patients who had acute kidney injury continues to do poorer and have poorer survival at 5 years. Few of them will require renal replacement therapy and will go on to develop CKD and end-stage renal disease, which is another big burden for them, thereby implying that the AKI which they had at that time progressed to irreversible kidney injury. If we want to see the major factors or predictors which can contribute to correlate with the acute kidney injury, we can see that patients having lower mean arterial pressure, those having lower cardiac index were more prone for AKI, and they had more of AKI. This correlation of cardiac index with AKI is generally not seen in patients with simple acute decompensated heart failure. That is basically seen more in cardiogenic shock. In acute heart failure, acute kidney injury is believed to correlate more with the mean CVP. In cardiogenic shock, it has good correlation with cardiac output as well as mean CVP, thereby implying that the pathophysiology which is happening in cardiogenic shock is slightly different than the same type 1 cardiorenal syndrome happening in patients with acute heart failure. So other predictors which can help are those, obviously those elderly requiring more vasopressors, patients on mechanical ventilation, those go on with patients who go on to develop positive fluid balance, and those requiring contrast exposure. As we know that creatinine is not a very good marker for renal injury, as it starts to rise a bit late. So if we follow creatinine, we come to know about renal injury. It's delayed by a few hours to few days. So there is all search for better markers for renal dysfunction, and cystatin C is one of that marker which is now clinically available and being used at many places, which can give some idea about renal injury in advance to creatinine, so that we have a time window in which we can intervene and improve the prognosis. As well as there is a new interest in looking at the tubular injury, because creatinine may rise or GFR may decline because of sort of pre-renal factors. So we want to see whether actually a kidney injury structural damage is occurring or not. And these tubular markers can give us an idea about whether structural renal damage is occurring at that point of time or not. And the most studied and at present favored marker is the tissue inhibitor of metalloproteinases and insulin-like growth factor binding protein 7. Along with that, kidney injury molecule 1 and fatty acid binding proteins are also being studied. But the problem at present is that we still don't know the clinical values of these markers and to how incorporate them in our routine daily practices, and at what time frame they should be done, how frequently they should be done. If they are increased, then what kind of intervention should be done which can actually change the prognosis of the patient. So at present, none of these have been shown to actually improve the prognosis, but I think investigations are going on, and we'll have more data in the coming years about that. We already have discussed about the clinical phenotypes of cardiogenic shock. From nephrology point of view, I will say that most common, the classical form, the wet and cold type, patients having pulmonary systemic edema as well as cold peripheries. Along with that, two more types which are now we know exist is the dry and cold type. In the dry and cold type are the patients who are generally diuretic responsive. So they are not having fluid overload, and these patients are mostly euvolemic. And the wet and the warm type patients, those who are having high cytokine and inflammatory markers, and so are having warm peripheries like seen in septic shock with vasodilation. As far as the treatment of the cardiogenic shock is with AKI is considered, again the focus will be on treating the cardiogenic shock as fast as possible, so as to reverse the basic pathophysiological process which is going on, along with protecting kidneys while doing the same. So the treatment is basically aimed at reducing the myocardial ischemia and improving the forward perfusion by treating the ongoing ischemia, maintaining the perfusion with the help of the vasopressors, and few of the patients who require mechanical circulatory support. It is also a known fact that patients with AKI generally need more of these interventions, and mechanical circulatory support is also more commonly used in them. In terms showing that these patients are generally sicker patients. I'm not going to go in detail of all of these, as these are separate talks, and I think all of you will be knowing all these things better than me. So I will just touch upon them from the nephrology point of view. So as far as inotropes is considered, norepinephrine is the preferred agent, and this preference has also come from studies which mostly involve septic shock patients. And while comparing the inotropes in them, norepinephrine was preferred. A small subset of those patients were also having cardiogenic shock, but most of the data is from the septic shock. Combination of dobutamine and norepinephrine is also preferred choice to avoid the renal injury. Dopamine, one thing is that low dose dopamine has actually no role at present in preventing the acute kidney injury, and when used as an inotropes, it is associated with increased mortality because of tachyarrhythmias or worsening myocardial ischemia. Similarly, epinephrine again is not the preferred. It has a worse renal outcome, more of lactic acidosis and more of microcirculatory failure. Among the newer inotropes, milrinone or a calcium sensitizing agent, again, none of them have shown to be beneficial from the renal point of view. I think rest will be discussed in the next slide. So most of these patients which are presenting with cardiogenic shock will be having some form of hypervolemia, but it is not a dictum. Many patients with cardiogenic shock can have euvolemia and may even be having maybe hypovolemic. Although to define the patient as cardiogenic shock, it is essential to rule out the hypovolemia and fluid challenge, and patient not responding to that are included generally. But it is very challenging to do fluid assessment in such patients. So for such patients, we'll have to gather all the history which they give, all the drugs which they are on, prior body weight, if it is available, present body weight, it is available. Along with that, the examinations, if there is an edema, how is the JVP, whether are there fine crabs, bronchi, hepatomegaly is there or not, and along with that, we may see IVC, B lines in the lung ultrasound, and other markers like BNP can help. But standalone one-time evaluation is generally not enough, and we need to do repeated examination to know how the things are going and how the things are doing. And many of these patients will, if needed fluid challenge, then it should be given in small amounts like 300 ml or so, and we should see the response which is happening to that fluid challenge. And based on the response, we should decide whether further fluid resuscitation is required or not. And this re-evaluation should be done daily, not only daily, multiple times per day to actually know how the patient is behaving to the therapy. Among the diuretics which can be used, we know this is just a recapture of the basic nephron and its functions. We know most of the sodium is absorbed in the proximal convoluted tubule in presence of heart failure or shock. Even up to 70-75% of the sodium will already be absorbed in the proximal convoluted tubule. Among the rest, most of it will be absorbed in ascending limb of loop of Henle, and the distal convoluted tubule will contribute around 5 to 10% of sodium absorption. But this is not fixed. It gets modified as per the situation of the patient, as per the drugs used. So the drugs which act on the proximal convoluted tubule like acetazolamide and SGLT2 inhibitors, they are not very good diuretics, because if the sodium absorption is even prevented there, loop of Henle has a large capacity to absorb sodium. So it's going to absorb the sodium. If we use thiazide diuretics alone, then we see that most of the sodium has already been absorbed before reaching the DCT. So they are again not as a standalone very effective diuretic. So the loop diuretics are the drug of choice for the volume overload status in these patients. Initially, it was thought, based on the multiple observational studies, that IV bolus as well as continuous infusion, if we compare, then continuous infusion is better. To remove all this confusion, a large randomized control trial was done for diuretic optimization. And again, this is in heart failure patients, not particularly in cardiogenic shock patients, and patients on inotropes were not included in, but I will just discuss it in short. It was 2x2 factorial design, and high dose versus low dose was compared, and bolus versus continuous infusion was compared. And at the end, there was no significant difference which was observed in them. But on the finer details, if we see, the patients who received higher dose, they responded partly earlier. They had more urine output at the 24-48 hours window, while the data was captured at 96 hours. And the BNP levels also reduced fast, but they also have slightly rise in creatinine at 24-48 hours, which actually became equal to what was there in the other group at 96 hours. One thing which these trials have shown us that diuretics we should have a protocol. We should give a dose of diuretic. If the patient doesn't respond, we increase the dose. If he doesn't improve, we add a thiazide diuretic. So we have to give the drug, watch for the response, and then modify our treatment based on the data we are getting. At the same time, the lower the GFR, the higher the dose of diuretics which we need to use, and a combination of a loop diuretic and a thiazide diuretics is actually a good option, because when we will give a loop diuretic, we will be preventing the absorption at the loop of the Henle. But what the kidney will do is it will increase its absorption in the distal convoluted tubule. So if we can block that also along by using a thiazide diuretic, then the diuresis is going to improve. Diuretic resistance and diuretic breaking both are very common in patients with heart failure and cardiogenic shock. Diuretic breaking phenomena is that when you give initially some dose of say furosemide 20 mg, the response is good, but when you go on repeating the dose, the response goes down. So generally the diuretic breaking in normal patients occur on chronic use, on long-term use, but in patients with heart failure, it can be seen very soon, despite patients having large extracellular fluid, ECF volume is high, still they get into this diuretic breaking and resistance. There are many reasons for that. The drug is poorly absorbed because of intestinal edema. So an IV formulation is preferred to oral in patients with failure. Also, to act, the drug has to reach the luminal side to bind its receptor. And if the patient has low GFR or there are high urea creatinine, the drug has to face the competition from the other organic acids, and it's not secreted on the luminal side. So it doesn't reach its site of action, so its action is reduced. If patients are having hypoproteinemia, then the volume of distribution is increased. These drugs have short half-life. So furosemide we use, it's having a half-life for around 1.5 to 2 hours. Its effects is going to last for 4-6 hours. Then as the effect goes off, kidneys are again going to retain sodium. So they may need repeated use. In patients with heart failure also, there is a reduced delivery of sodium because of reduced GFR. There is increased distal absorption of sodium because of increased renin, angiotensin, aldosterone, which is there, which is acting. When we compare diuretics with the ultrafiltration, the two large studies, UNLOAD study and the cardiorenal syndrome heart failure study, both of them shows that both are good enough. Instead, in the later studies, they have shown that the creatinine rose by 0.2, 0.3 mg% more in patients who were undergoing ultrafiltration compared to diuretics. So as a first step, diuretics are the preferred choice. And if the stepwise increase in diuretics is not helping and the patient is in pulmonary edema, then we may consider ultrafiltration. But the first choice will be diuretic use. As far as the renal replacement therapy is considered, generally patients in stage 2 or higher will need these renal replacement therapies. Most of them are not going to tolerate the intermittent hemodialysis, and they are going to need some form of continuous renal replacement therapy, whether hemofiltration or a hemodiafiltration. When the fight between late initiation versus early initiation comes, again the data is mostly from sepsis, septic shock trial, critically ill patients rather than from cardiogenic shock trials. So these patients, there is no difference in outcomes whether you initiate renal replacement therapy early or late, because most of the mortality is not directly because of the kidneys. So the outcome, there is not a big difference. There are some mandatory indications for renal replacement therapy like refractory hyperkalemia, refractory volume overload, refractory acidosis, advanced azotemia, or uremic encephalopathy. In clinical practice, obviously, we don't want our patients to land up with these problems, and we should intervene 1 or 2 steps before actually these things happen to him. In the ventilatory support, as many of these patients will be needing the ventilatory support, we should prefer the low tidal volume so as to prevent the venous congestion, and which will further reduce the renal perfusion and worsen the kidney injury. When we use PEEP, we should start with a smaller PEEP, although moderate amount of PEEP has shown to improve the left ventricular myocardial oxygen delivery. Except in patients who are hypovolemic or who are having right ventricular failure, in that if we use higher amount of PEEP, it can actually worsen the venous congestion, the venous output, and worsen the kidney injury in turn. In these patients, it will be better if we first correct the hypovolemia, make them euvolemic, and then increase the PEEP. Or if the patient is having right ventricular failure, we should start at a lower PEEP, say 3 centimeters of water, and then slowly up titrate these. Throughout the treatment, whatever interventions we do, we have to at the same time monitor the result of that in the form of, like, if we are giving ventilatory support, we have to see the blood gas analysis and have to see lactates and revise our ventilatory strategy as per that. Increasing lactates are one of the very good predictors that patient is going to land up with acute kidney injury, as they indicate that there is microcirculatory failure which is happening. So my take-home message will be that acute kidney injury in cardiogenic shock is quite common, and it has significant morbidity, mortality, and economic burden to the patient. It has long-term effect on the patient outcomes. Higher the stage of acute kidney injury, poorer the outcome, mandating early action. At the same time, we need better strategies which are need of the hour to improve the outcome of such patients. I have not written particular treatment which should be given. That itself shows that at present we are lacking in strict, good evidence-based treatment which can actually change the outcome of such patients. And more investigation and research is actually required in these group of patients. So thank you.
Thank you, Ajay, for that excellent talk. I think what we can do, we can save the discussion after the next talk, because the cardiorenal syndrome and the next talk by Dr. Suresh Rao sir has overlapping topics, and probably a discussion after these two talks will give us more insight. So let me introduce Dr. Suresh Rao. Dr. Suresh Rao is a co-director of heart and lung transplant at MGM Healthcare in Chennai. He has one of the highest experience in the country of managing patients with cardiogenic shock, patients on ECMO, LVAD, pre-transplant and post-transplant. And the topic he's going to enlighten us on ICU management of shock, how to do a preemptive identification, escalation and de-escalation of the therapy, which involves the fluids and the inotropes. It's a very important topic, as Ajay had also pointed out, that patients can be euvolemic and still have a cardiorenal syndrome. So I think, and then he also pointed out a lot of inotropes have poor outcome and increased mortality, which we can have inputs from our cardiac surgical team as well post this talk. So Dr. Suresh Rao sir, over to you.
Yeah. I have to share my screen. I think somebody has to unshare.
Yeah, Ajay, can you unshare your screen?
Yeah. Good evening, all. I think it's a great pleasure to be part of this symposium. I thank Dr. Ravinder Singh for inviting me, and also congratulate him for designing the excellent flow of topics for this symposium. This is MGM Healthcare, where we provide heart and lung transplantation and mechanical circulatory support services. Now, Dr. Dinesh has explained the cardiogenic shock definition and various types of shock. So what we are targeting is the end organ hypoperfusion and prevention of end organ hypoperfusion due to decline in cardiac output, because the mortality rate is very high, around 30% or more. And in 58% of the patients with acute coronary syndrome, there is requirement for intravenous vasoactive medications, invasive hemodynamic monitoring, and mechanical ventilation. So what are the etiologies for cardiogenic shock? It may be acute coronary syndrome or acute on chronic heart failure. It may be because of the post-cardiotomy, post-cardiac surgical situation, may be related to valvular heart disease or uncontrolled arrhythmia, cardiac tamponade, maybe because of the myocardial contusion due to trauma, LVOT obstruction, or acute pulmonary embolism. Now, 70% of the cases of cardiogenic shock are related to myocardial infarction. And in 79% of the acute cardiogenic patients will have left ventricular failure. 7% will have acute mitral regurgitation, 4% may have VSD, 3% may have isolated right ventricular infarction, or 2% may have tamponade or cardiac rupture. Some of the rare causes are LV outflow obstruction, myocarditis, myocardial depression secondary to sepsis or cardiomyopathy, myocardial contusion, acute aortic insufficiency, or medication toxicity or tachy or bradyarrhythmias. So it is very important to preemptively identify the cardiogenic shock, otherwise the outcome will be worse. So how will you identify the cardiogenic shock? Some of the clinical signs of impaired perfusion are cold extremities. If you look at the capillary refill in the fingertips, it will be delayed. They may have hypotension. Their pulse pressure, that is the difference between the systolic blood pressure and the diastolic blood pressure, will be narrow. They may have tachycardia or bradycardia. They will be tachypneic. They will have, they'll be in confused status. There may be altered mental status. They also may have oliguria. Dr. Rajesh Singh, in fact, explained earlier about the cardiorenal syndrome. They can have S3 gallop or new onset murmur. They also may have signs of congestion, especially with chronic heart failure. There will be jugular venous distension, pulmonary rales or crackles. Again, peripheral edema, cardiac ascites, hepatomegaly, orthopnea, or signs of acute on chronic heart failure. So can you predict the cardiogenic shock before it happens? See, there are use of artificial intelligence, in fact, complex algorithms, machine learning, and signals from various hemodynamic monitors, pulse wave analysis, and other lab parameters. They can predict the hypotension few hours before it can happen. This is one such commercially available monitor. You can see the mean arterial pressure is 75, but hypotension prediction index is 88%. That means this patient is going to have hypotension in the next couple of hours. We may have to do some lab investigations. Lactic acidosis will be there. It may not be specific to cardiogenic shock. It just indicates that there is tissue hypoperfusion, anaerobic metabolism, and release of lactates. Doing troponin helps in identifying the cause of acute cardiogenic shock. The mixed venous oxygen saturation or central venous oxygen saturation will help in identifying the low cardiac output status. Chest X-ray again helps in detection of pulmonary edema. NT-proBNP may not be raised in acute cardiogenic shock, but underlying chronic heart failure can be detected with the NT-proBNP. Now, ultrasound definitely plays a major role. The echocardiogram, you can make out the left ventricular contraction as well as the right ventricular function assessment. The IVC diameter helps us in assessing the volume status if it is more than 2 centimeter. And the lung ultrasound again helps in detecting the pulmonary edema, looking at the B lines. This is the rapid ultrasound in shock evaluation, which can be done in the emergency department. In the rush protocol, they look at the pump, basically look at the LV function and RV function, then look at the tank, that is the volume status, looking at the IVC, any leaks in the valves, and the pipe. Pipe is basically you look at the aortic dissection, aneurysms, DVT, or pulmonary embolism. You can also look at the high map approach where you look at the heart, IVC, Morrison's pouch. This is for the chronic heart failure, then aorta and deep veins, and presence of pulmonary edema, pneumothorax, etc. Now, monitoring the central venous oxygen saturation used as a surrogate marker for mixed venous oxygen saturation, especially if you don't have a PA catheter. Now, if the mixed central venous oxygen saturation is less than 60, It supports the diagnosis of cardiogenic shock. This also can be used as a trend and to see the response to the therapy. PA catheters, again, it's a vital diagnostic catheter. However, may not be used in all cases. Nowadays, we get continuous cardiac output catheters so that you can continuously monitor the cardiac output and also look at the response to therapy. You can also determine the cardiac output by invasive arterial blood pressure. Looking at the area under curve of the arterial trace, you can determine the stroke volume. Stroke volume into heart rate gives the cardiac output. And if you connect the CVP, it also calculates the systemic vascular resistance. So it is important to know the cardiac output and SVR if you are going to treat these kind of patients. You can also measure the cardiac output with non-invasive methods. This is one such clear site commercially available by Edwards Life Sciences. It will give a cardiac output. It also gives a continuous cardiac output. Now there are some hemodynamic parameters which are useful in managing these patients. One is central venous pressure. Basically, it reflects the RA pressure or RV endostolic pressure. Then the pulmonary capillary wedge pressure, which reflects the LA pressure or LVEDP. You can measure the cardiac index because the PA catheter with the continuous cardiac output also gives the cardiac output. You can also measure the stroke volume index and right ventricular ejection fraction. Now there are some derived hemodynamic parameters are there. The important one is calculating the systemic vascular resistance. If you know the mean arterial pressure and the RA pressure and the cardiac output, you can actually measure the systemic vascular resistance. You can also measure the pulmonary vascular resistance, that is nothing but the mean pulmonary artery pressure minus pulmonary capillary wedge pressure divided by the cardiac output. Now, the whole idea of maintaining the cardiac output is to supply good oxygen to the tissues. So oxygen transport parameters are equally important. So what is important is to know the oxygen delivery to the tissues. The oxygen delivery depends upon the cardiac output, hemoglobin, and the saturation. So if you have all these parameters, you can measure the oxygen delivery. And you can also look at the oxygen extraction by the tissues, which can be measured by looking at the arterial blood gas and venous blood gas. And you can also look at the mixed venous oxygen saturation. Suppose you have a low cardiac output situation, the oxygen delivery will be less. So obviously the mixed venous oxygen saturation also will be low. So what are the various monitoring lines are required during managing the cardiogenic shock? CVP, it helps in monitoring the central venous pressure, as well as useful to give the various vasoactive medications. Arterial blood pressure monitoring, again, it helps how the body is responding to various vasoactive medications. The central venous oxygen saturation, doing it every 4th hourly helps whether the patient is responding to your therapy. And as Ajay Singh pointed out, urine output every hour is very important. And in patients who are not responding to regular therapy, PA catheters may be useful to monitor the response to therapy. Now, what about the fluids and ionotropes in cardiogenic shock? That is the main area of topic. So there are various stages of shock. Initially, it is reversible. At a later stage, it is irreversible, resulting in end organ failure. So it is very important to detect the early shock and treat them. So as already explained by Dr. Ajay, by Dinesh, there will be wet shock and dry shock. I'll not go into details. So if you are modifying the cardiac output, you have to modify either the heart rate or the stroke volume. Heart rate depends upon the autonomic innervation and various hormones, whereas stroke volume is nothing but end diastolic volume minus end systolic volume. So the end diastolic volume depends upon the preload, whereas end systolic volume depends upon the contractility, afterload, and other parameters. What about the use of fluids in cardiogenic shock? Most of the times, their LVEDP will be high, so you should not administer fluid unless you do the clinical assessment for preload insufficiency. And as I said earlier, cardiogenic shock is often associated with high LVEDP. In fact, they will require diuretic therapy to reduce the congestion. With acute MI, there can be inflammatory response with the release of leukotrienes and other inflammatory markers. So their SVR may come down. So there is a role for fluid challenge. You can give 200 ml initially. If it is responding, you can give some more. However, the maximum 500 ml fluid can be given as a fluid challenge in these patients. Coming to the inotropes and vasopressors, the outcome is poor if the mean arterial pressure is less than 65 millimeter of mercury or systolic blood pressure is less than 90 millimeter of mercury for more than 30 minutes. Now, if you use inotropes, it will increase the contractility and increase the cardiac output, whereas vasopressors can increase the vascular tone, so it can increase the blood pressure. So it is important to know that augmentation in cardiac output is beneficial, but it should be balanced against the risk of developing tachyarrhythmias and increasing the myocardial oxygen consumption. You try to increase the cardiac output, your myocardial oxygen consumption may increase. Now, what about the milrinone, levosimendan, as suggested by Dr. Ajay? It's not a useful thing in acute cardiogenic shock with low blood pressure because it may reduce the blood pressure further. However, it is very good drug in chronic heart failure. So this chart actually shows the various inotropes and their mechanism of action. Dopamine at 5 to 10 microgram per kg predominantly acts on beta-1 receptors, which may increase the contractility and heart rate, whereas norepinephrine predominantly acts on alpha receptors, less on beta. So basically it increases the SVR and partially increases the cardiac output, whereas epinephrine again increases both the inotropic activity as well as vasoconstriction. Whereas dobutamine predominantly beta-1 increases the cardiac output, and isoprene again it's not used in the acute cardiogenic shock unless there is severe bradycardia. So in acute cardiogenic shock, norepinephrine is the first drug of choice. Dopamine again it is questionable because it increases the chronotropic effect, may cause tachyarrhythmias. And in case more inotropic support is needed, you can go for dobutamine. Adrenaline, again, question mark. In fact, the overall mortality benefit is less with the adrenaline. Milrinone, again, levosimendan, we need to be very cautious while using these patients in acute cardiogenic shock. Now, what is the role of mechanical ventilation? Is there any role for routine oxygen therapy? No, because our target is to have a SpO2 of 90% or above. If it is less than 90%, then you can use oxygen by mask. Otherwise, hyperoxia in fact cause harm. It can cause coronary vasoconstriction. It may produce oxygen-free radicals and reperfusion injury. If the oxygen saturation is still less than 90%, you can go for non-invasive positive pressure ventilation. However, we need to be very cautious if the cardiogenic shock is preload dependent, especially if there is right ventricular dysfunction. However, non-invasive positive pressure ventilation is beneficial in left ventricular failure. What about high flow nasal oxygen? It may be beneficial. However, we don't have enough studies. If the patient is dyspneic, hypoxic, there will be increased work of breathing. So that time intubation and mechanical ventilation will help. However, one important thing to remember is that if they have hypotension, that has to be corrected first before intubating. Otherwise, they will have cardiac arrest and you may not be able to resuscitate them. And once intubated, you can go for lung protective ventilation. If the oxygen saturations are low, you can increase the PEEP. So to summarize the take-home messages, BP, cardiac output is not blood pressure, because if the blood pressure is normal and SVR is high, the cardiac output may be low. Or you can have high blood pressure, low cardiac output, high SVR. So as Dr. Ravinder Singh pointed out, just having normal blood pressure doesn't mean patient is not in cardiogenic shock. You have to look for early signs of shock like heart rate, blood pressure, cold peripheries, presence of tachypnea, oliguria. So it is important to detect all these things so that they can be treated early. There is a role for artificial intelligence. Of course, it is futuristic. I'm sure some monitors will come which can detect the occurrence of cardiogenic shock at least 2-3 hours before actual onset of cardiogenic shock. Coming to the fluid challenge, we need to be very careful. You can try with 200 ml and maximum of 500 ml, not more than that, unlike septic shock, where you can give 1 to 2 liters of fluids. And coming to the anatropes, norepinephrine is the first drug of choice. And if any more anatropy is required, you can add dobutamine. You need to be careful with dopamine, adrenaline, levosimendan. And oxygen saturation should be maintained above 90%. Unless it is below 90%, there is no role for oxygen supplementation. Hyperoxia may be harmful. Other important thing to remember is that not to beat the tired horse. If the blood pressure, cardiac output is not improving, it is better to go for early mechanical circulatory support services. I'm sure Dr. Chakravarti will highlight on that. And finally, treat the underlying cause. Unless you treat this, I don't think you will go anywhere. And thank you.
Thank you, sir, for that excellent talk. And let me tell you, it was so educational that we definitely have learned a lot of things from your talk. I remember when you had come to Jaipur in 2019, your talk on PA catheter was appreciated by everybody in the audience. So we can have some discussion. Let me ask Dr. Rajiv, sir, is he there?
Yeah, I'm there, sure.
Sir, questions from your side, your thoughts on this complex scenario of ICU management of cardiogenic shock?
I think...
Any questions you want to ask, sir?
Yeah, I mean, thank you, Dr. Suresh. We remember your presentation way back in 2019. And you started from where you left in 2019. So it's as good or maybe better than what it was at that time. It's a lucid presentation for beginners as well as for teachers also. So I think what is emerging out from all the discussions which we have been holding is, which is the last line of Dr. Suresh Rao's presentation, is that don't flog the tired horse. And all said and done, these basic clinical approach as well as the basic treatment strategies of cardiogenic shock, they are important. But at the same time, I think one should be aware of the newer technologies which are available now for treating this complex scenario. They should be aware so that they can apply themselves, learn about them, or maybe at least refer or tell the patient attendants that certain more newer modalities are available for treatment of such patients.
Dr. Buddhaditya, are you there?
Sure.
Yeah, Dr. Buddha, go ahead.
Dr. Rao, congratulations. That was a wonderful talk. It was very lucid. And I guess everybody in the audience is just enthralled listening to you, coming from the master. I just have one question, Dr. Rao. With regards to the fluid, the level of fluid you want to administer to a patient in shock. Do you rely on the echocardiography to give you a few pointers other than the conventional numbers which the CVP catheter or the PA catheter gives? How reliant or how reliable is the echocardiography to sort of give a sense of the right side filling or the IVC? What's your take on that, sir? Thank you.
I think there are so many parameters. You can't rely on one single parameters. Like initially we used to look at the IVC diameter and assess the fluid status. It is not one such parameters on which rely upon. If you have a central venous pressure monitoring, IVC diameter, then you can look at the filling of the right ventricle and the filling of the left ventricle. So and also you can look at the arterial pressure waveform if there is any pulse pressure variation, stroke volume variation. At present monitors, you can also look at the stroke volume variation. All those things are possible. So we look at all the parameters, then definitely echocardiography will help in assessing the volume status, especially suppose if the IVC size is small and there is variation with the respiration, definitely patient's volume status is less, in the sense you can use a fluid challenge. But if the IVC is full, it is more than 2 centimeters, there is no respiratory variation, it doesn't mean that the patient's volume status is, still there is a possibility of response to fluid challenge.
Just to extrapolate this question further, Dr. Rao, I'm asking this in the light of the various mechanical circulatory support devices which we have, in which you usually have drainages of the right heart system, or you have cannulas coming in. So how accurate are the conventional modes of monitoring the right side pressures, as in CVPs or PA catheters, vis-a-vis working on the echo? What are your thoughts on that?
No, when you have a RVAD or LVAD, the echo basically you look at the interventricular septum. When you have a BIVAD, for example, where the RVAD is there, LVAD is there, you look at the interventricular septum. If it is, for example, bulging into the RV, obviously your and you need to monitor the pulmonary capillary wedge pressure. For example, you look at various parameters. As I said, LA pressure. Then you look at the interventricular septum, interatrial septum. Suppose if the interatrial septum is bulging into the LA, that means your RV preload is more as compared to LV preload. So you can increase the RVAD flow. At the same time, you have the interatrial septum is into the right and LA is full. So obviously you'll have to increase the LVAD flow. So echo is definitely useful. And in fact, post cardiac surgical situation, you may not have good transthoracic window. In that case, we use transesophageal echo to look at the various chamber dimensions. Yes, definitely it is useful.
So Dr. Suresh, it's a request from our side that you should stay until that ECMO LVAD or maybe till the end of the program, because you have one of the highest experience in the country of using ECMO and LVAD for heart transplant and also during the COVID era. So we would also like to enlighten from you about this topic. Questions from Dr. Dinesh, if you are there, Dr. Ajay?
Yeah, Dr. Ravinder. So
yes.
Actually one thing, Dr. Suresh, which you have highlighted, that normal VP doesn't mean shock. That is not always true. The one variety, that normotensive shock, we are having most of the time the patients which are in agony and we are thinking shock, but that patient is having VP of around 100, 110. So that time we have to measure the tissue hypoperfusion markers. Like we have to take ABG within 1 to 2 hours, and we have to measure that lactate levels or bicarb levels. Means no high SVR with normal BP, but lactate levels may be high, and that patient can have cryptic shock. So that is a dangerous situation. And normal BP doesn't mean that you are not having any cardiogenic shock. That you have highlighted. That is, I think that is a very good point we have to see in our emergencies.
So I think Dr. Dinesh, you highlighted such an important point. Let me ask you this question to you and Dr. Suresh Rao, sir, and this is for benefit of all our audience. Do you both recommend doing an ABG of a patient who comes to the ER with cardiogenic shock and normal blood pressure and not on any inotrope support? So the important thing which Suresh sir had highlighted is the importance of clinical examination. We have always forgotten that, capillary refill time, cold clammy extremities, tachypnea, decreased urinary. So on top of it, do you recommend doing an ABG and documenting lactic acidosis?
Yeah, that we are doing always in our
You're
emergency. Yeah, we are doing this as soon as patient is coming, patient is cardiogenic shock, we are immediately taking ABG levels and we are measuring bicarb and lactate levels. That is a routine now in our hospital. And
So
we are finding that many of the times patient will be having borderline BP, but still lactate levels be on higher side. And those patients are having higher motility if we are not managing in time. So that we should do in each and every emergency. ABG as soon as possible.
That's a very good point. Dr. Suresh, would you like to comment on that?
Yeah, definitely. I do agree with you. And in fact, the level of care actually nowadays is excellent in most of the hospitals, especially emergency medicine has become a specialty by itself. So they do an arterial blood gas in low cardiac output situations. So it also helps in assessing the therapeutic response. For example, lactate levels were 2 and it becomes 4. That means we are not doing enough. Whereas if it is 4 and it become 2, we know that we are doing the right thing.
So let me ask Dr. Ajay. Ajay, are you there?
Yes.
So do you think this ABG and when we document this lactate level can predict that such and such type of patient is at high chance of developing a cardiorenal syndrome if not managed properly in next 6 to 12 hours?
Yeah, definitely it can help us because rising lactate in a way shows that there is microcirculation failure which is going on there, and that's why the kidneys are also at increased risk.
So do you suggest that we should do anything preemptively for such patients other than treating the underlying cause to kind of decrease the incidence of cardiorenal syndrome? Would you suggest using any particular drug like maybe N-acetylcysteine or high dose statins, or just treat the underlying cause?
No, I think till now no particular drug has actually shown that they act or they improve the outcome. The only thing which will help is to treat the underlying illness. So favoring that, I will say that if somebody is in a cardiogenic shock with acute kidney injury, sometimes we see that cardiologists wait for kidney functions to stabilize and then they say they will intervene. I will say that it is better that you intervene early. No, you initially stabilize the patient and then intervene as soon as possible. Anything which can actually improve the cardiac function will ultimately lead to improvement of renal functions.
So Dr. Kailash has joined us from Italy. He is doing his advanced intervention cardiology fellowship there. So Dr. Kailash, do you have any inputs? How would you manage such patients differently? Do you routinely use CPO, cardiac power output, for your cardiogenic shock patient? And my second question is, should we calculate CPO for our patients who present to the emergency in cardiogenic shock?
No, sir. Routinely we don't measure the CPO, and they are just treated usually what we do there. But in the intensive care unit, they do all the measures. They do the right heart catheterization, pulmonary artery catheter they put always, and besides there is no new thing.
Okay. Anything which you want to add?
No, just I want to ask Suresh Rao sir one question, that in the studies there is no clear evidence about the bolus versus continuous infusion of diuretics. But still, I have seen here and India also in the good hospitals, good ICUs, the most of the heart failure specialists and the intensivists prefer to go for continuous infusion of diuretics rather than bolus dose.
Dr. Suresh, continuous infusion of diuretics versus bolus, and then Ajay can also throw some light on that.
I think Dr. Ajay is the best person to.
Yes,
So there, I don't want to comment.
Your experience, how do you manage in your
Yeah,
center? Because
usually
you
we
do
start
so many cases.
Sometimes we do give bolus, but most of the time we start early because once the urine output starts below 0.5 ml per kg, that is the time to react. We start the infusion. So we don't wait for the real oliguric.
Okay. Ajay?
Yeah, I would say that when we compare bolus with the continuous infusion in the clinical practice and the experience, the amount of dose which we need to give, say if you are giving a continuous infusion, we are generally using around say 200 milligram of furosemide in 24 hours, 300 milligram. Generally, clinicians don't prefer to give such high doses in bolus. No, you will be needing to give 100 milligram IV 12 hourly or something like that. Then I think there is a block in mind that think that this may cause actually nephrotoxicity or this may cause acute worsening of the hemodynamics. So most of these patients are only on vasopressors. So generally we prefer a continuous dose of diuretics. Also the gap which is going to come between the two doses in which the patient is drug free and kidneys are again starting to retain the sodium. That kind of thing is also there. Although in studies, the main randomized studies showed that both are equal, but practically when we see that continuous infusion generally gives better results. So initial small bolus followed by continuous infusion is what we generally do. We prefer.
So my question to Dr. Dinesh, because you highlighted the importance of use of new classification, do you think that we should routinely calculate CPO as soon as the patient presents to the ER, and our therapy of escalation and de-escalation, be inotropes, be fluid, be mechanical circulatory support, be it NORAD or any other inotrope, should it be guided by CPO? Because in the trial and as well as in your presentation, you said that CPO is the best predictor of outcome and mortality in cardiogenic shock patient. Dr. Dinesh?
Yeah, sure. Ravindra, if it is possible in our settings, we should measure it because all the new trials are checking this CPO and index also, cardiac power index also. So that is a very good marker for LV contractility and the peripheral perfusion, which we are talking about. So, but we are not having that much settings that we can have these all intra-arterial lines and all those things. But we should try to measure something. So if it is possible, you should measure.
So maybe after this symposium, we all can try measuring that CPO. Dr. Pawan Mehta, any questions, any thoughts from your side? Dr. Pawan is a senior intervention cardiologist with us.
I just want to make one.
Yes. Go ahead, sir.
I think it's a very good point about the cardiac power output. If you know the cardiac output, blood pressure, you can make out the CPO.
Yes.
So how to measure the cardiac output? You can do it with the echo in the emergency department. We just need to look at the VTI across the LVOT, measure the LVOT diameter. So you'll get the stroke volume. Then you can, into heart rate, you are getting the cardiac output. So you can easily measure the CPO in the emergency department itself. And it's just that we need to develop that system. I think it's a very good take-home point, and we can try to implement.
I think that's a very good point which you highlighted, sir. And that is what we would do in a patient who's on ECMO. How do you calculate a cardiac output? Also in a patient who had low flow, low gradient AS, you trace the VTI, you can get a stroke volume and multiply by heart rate. And so I think we should maybe start using this CPO. Dr. Pawan, any questions from your side to both of them, both the speakers? Because this was an important topic for everybody, intensivists, cardiologists, clinicians. Dr. Pawan, can you hear us? So Dr. Govind, are you there?
Hello. First of all, I want to thank Dr. Ajay and Dr. Suresh sir for enlightening us with such a nice topic, because fluid management is very difficult in patients with acute renal injury and cardiogenic shock patients. My question to Dr. Ajay is, can you please show some light on role of cystatin C in place of creatinine? So how frequently can we measure systemic C and how it will help?
Actually, cystatin C came to use because creatinine use was having some drawbacks. One of the drawback was that till large part of the kidneys stop functioning, it doesn't starts rising. And second, there is also a tubular secretion of creatinine. So it can sort of hide the actual renal dysfunction which is going on. And creatinine takes time to rise. So in acute kidney injury, creatinine is not a very good indicator of the ongoing glomerular filtration rate. And all the estimated GFR formulas which are there to calculate the GFR based on creatinine are actually validated for chronic kidney disease patients who have a stable creatinine. So somebody who is having a creatinine which is changing daily, then that creatinine actually doesn't show that real GFR. For example, if a patient is anuric, so his creatinine today is 1, tomorrow his creatinine may be just 2. But if he is anuric, then definitely his GFR in reality is going to be less than 15 ml or 10 ml per minute per 1.73 meters square. But the creatinine is not reflecting that. So we needed a marker which can reflect glomerular filtration rate better. So cystatin C is a molecule which is freely filtered from the glomerulus and is not affected by the tubular secretion or reabsorption. But again, that cystatin C, the advantage which thought we will come to know the acute kidney injury earlier, that is there. We can diagnose acute kidney injury a step ahead than we can with the creatinine. But in the investigations, actually, it has not shown to improve the hard outcomes in terms of the mortality benefit or in terms of length of hospital stay. So it has not actually converted into that. So we still don't know how to use cystatin C better. But those centers which are using cystatin C, it is being used like a creatinine. You can do it daily. It's a blood marker, and then you can follow it for the GFR.
Thank you so much. One more question, that in emergency, if we are looking like lactate levels in ABG, so how can we decide whether this lactate will be raised because of septic shock or cardiogenic shock? Because in cardiogenic shock, we cannot give much of fluid. In case of septic shock, we have to give the fluid to the patient.
So I think that question can be answered by Suresh Rao, sir. First is we identify, we label the patient as cardiogenic shock versus septic shock. Go ahead, sir.
I think it's a very good question. See, we just that septic shock SVR will be very low. So you just, the cardiac output is not an issue. In fact, they will have hyperdynamic circulation. You'll have bounding pulses. If you measure the venous saturation, it may be 80%, whereas in cardiogenic shock, your venous saturation will be 60, 50 or lower than that. And if you look at the SVR, that is, if you know the mean arterial pressure minus CVP by cardiac output, again, SVR will be very low. So and there will be lactates, then acidosis.
Any more thing, any other thing which can be seen in ABG apart from lactate that can show whether it is cardiogenic shock?
There may be low bicarbonate, metabolic acidosis, and they also may be tachypneic, hyperventilation, sometimes PCO2 may be low, altered mental status, and procal may be high, counts may be high. So
this brings to the important point that there should be an ultrasound based technology in the AR itself. An ultrasound based, either a normal ultrasound or a 2D echo, should be placed in the ER of a hospital which is managing cardiogenic shock syndrome. But if you ask me how do I answer this question, I come back to the slide which was shown by Dr. Suresh Rao, sir, the importance of clinical examination. How do you identify whether this patient is likely to have a cardiogenic shock versus a septic shock? So I think if there are no further questions or comments, now once we have identified the cardiogenic shock, once we have done a management of the cardiogenic shock, and we understand that now we need to treat the underlying cause. So Dr. Suresh Rao, do you do CPU monitoring routinely in your practice, cardiac power output monitoring?
We do whenever we put Impella because it has got an
Yes.
inbuilt
Yes.
monitor.
Yeah.
Otherwise, sometimes we do calculate. In fact, patients with chronic heart failure coming for heart transplantation as a preoperative check, workup, we do CPO, we calculate PAPI and all those things. I don't know how much significance it is there for these case patients.
Maybe once we start doing it, probably we'll be knowing it more, sir. So we move on. Go ahead,
one
Dr.
question, sir, Suresh Rao, sir. How does this CPO matches with LVDP by DT? Which is better, or by echo? If you are measuring CPO and LVDP by DT in echo for that contractility or LV contractility performance by DP by DT?
No. Actually, I didn't get the question. If I
means sometimes we are measuring LVDP by DT by echo to see the LV systolic functions or LV contractility.
Yeah. Okay.
And the same or more advanced thing which is used in trials is CPO. So you are checking both. How this comparable?
That's very difficult to say because, as I said earlier, it's not that we do CPO regularly. So in a given situation, we may specifically look at it. Otherwise, I may not be able to say as a routine practice.
Okay. Any experience with this DP by DT? Are you measuring it regularly? Because we are measuring it regularly, and this below 1,000, it is this showing that the patient will be worsening further if you are not acting immediately. So, any experience with this DP by DT measurement?
Probably I may not be able to.
So I think that's the question, Dr. Dinesh, which you asked is, I think CPO is a more comprehensive parameter to measure the outcome, and your DP-DT is integrated into the CPO. So if you look at the CPO is cardiac output and mean arterial pressure. So the DP-DT element is part of cardiac output. The mean arterial pressure also includes your stroke volume, systemic vascular resistance, and your cardiac output in total. So I think probably the reason why cardiac power output CPO is a better parameter is because it integrates the heart as well as the peripheral vascular system and how they interact. So probably that is the reason
because
why
that is better. Actually, I was thinking that DP by DT is very easy to measure. Anybody can measure, and that CPO is very difficult.
And you need to work hard.
Yeah.
So I think the reason why I'm stressing on that is because it just came to my mind that if we start measuring CPO for all our cardiogenic shock patients, maybe after next year, once we do this symposium again, probably we can enlighten ourselves that whether it was helping our patients or not. So we move on to the next lecture. The next lecture is will be given by Professor Rajiv Bagrata sir. Dr. Rajiv Bagrata sir is head of Department of Cardiology at SMS Medical College and Hospital. He has contributed immensely to the field of cardiology and intervention cardiology in India as well in Jaipur. I am his student. I have done my DM cardiology from SMS Medical College, and it is my privilege to invite sir for his talk on PCI in acute MI cardiogenic shock, timing, culprit versus total revascularization. Over to you, sir.
Thank you, Dr. Ravinder. It's indeed a pleasure to be part of the symposium for the second time in succession. And also, thank you for bringing me out of this COVID scenario. At least there's something more happening in the world besides COVID. As you understand that our hospital has been turned into a COVID hospital, and most of the work has been dedicated to COVID these days. So, this is a refreshing change for me, talking about and discussing about something other than COVID. So, can I start sharing the screen?
Yes, sir. Yes, sir. Go ahead.
Just hold on. Yes. Yeah, so it's being seen by everybody. Can everybody see that?
Yes, sir.
Yeah, okay.
You can see.
So as has been, we have been talking over the evening, the definition of shock beautifully demonstrated, discussed by Dr. Dinesh. There's a clinical element to it, followed by a hemodynamic part to the definition of shock, which has been the similar in major trials over the last many years. Dr. Suresh Rao had told us that most of the causes of cardiogenic shock in acute myocardial infarction is because of at least systolic dysfunction, and there may be some cases of mechanical complication like VSG or acute MR, which may lead to cardiogenic shock in such cases. It has been amply demonstrated, emphasized upon till now, that the clinical scenario decides the prognosis of a patient. If we want to preempt the diagnosis and the treatment of cardiac shock, few features, the clinical features like the patient being a diabetic or a patient who has had a previous infarction or anti-infarction, for these patients, we have to be more vigilant because they may end up into cardiac shock and may have to be treated more aggressively and maybe have to be monitored more frequently. As we understand, cardiac shock is having a hemodynamic characteristic of decreased cardiac output with increased SVR and increased pulmonary artery wedge pressure. So from here on, once we have diagnosed a patient to be suffering from cardiac shock, we have amply demonstrated the prognostic classification of the cardiac shock. The strategy which has been basically we've used for treating these patients involves a very important component of myocardial revascularization. As we understand that cardiac shock is mainly because of acute MI. Most of the cardiac shock are because of acute MI and because of systolic dysfunction. So until we take care of the revascularization of the culprit arteries or the other arteries which are found to be diseased, we probably cannot improve upon the prognosis of these patients. So there has been a long-ranging debate about it. The debate has been raging for quite long about how to treat these patients, how to revascularize this patient. And way back in 1999, the shock trial had demonstrated very clearly that those patients who suffer from acute MI with cardiac shock, and if they are treated by conservative, try to stabilize conservatively, versus those patients who have been treated, managed by angioplasty or PCI, there has been found to be lower mortality from all causes at 6 months. Those patients who had been treated invasively, they had lower mortality. So much so that at 1 year, the shock trial showed that there was a 13% increase in survival in those patients who underwent early revascularization as compared to those patients who had to be stabilized medically. From here on, after it was established that the invasive strategy is better than the medically treated patients in this very sick group of patients, came on the debate about how to treat these patients. Should we treat the patients, should we treat the culprit artery only, or the non-culprit artery or the non-IR arteries, infarct artery should also be addressed at same sitting. The National Cardiovascular Data Registry showed that multi-vessel PCI is showing more deaths, more renal failure as compared to those patients who underwent only PCI of the IRA. The story continued with the registry from EHS, which showed again that the parameters were bad for these patients who underwent PCI of the multiple vessels in the same sitting. And it also continued with the German PCI registry. As if this was not enough, there have been conflicting results from different studies, with only a couple of studies like this study from Milet et al. Or maybe Park et al., which shows that mortality with the multi-vessel PCI is better as compared to those patients who have got PCI treated only of the culprit artery. Only these two studies of these multiple trials show that the mortality was better with multi-vessel PCI. All the other studies have only added to the confusion. So in year 2014, the European Society of Cardiology had recommended that the primary PCI of the culprit vessel is the strategy of choice in those patients who suffer from cardiac shock from acute myocardial infarction. And the non-culprit vessel PCI should be only restricted to those patients who have got either multiple lesions in the non-infarcted artery, they are unstable, or the ischemia is persistent even after the PCI of the culprit artery has been addressed. And then in 2017 came the culprit shock trial. The culprit shock trial had patients of both acute ST elevation MI as well as non-ST elevation MI, and those patients who presented to them with cardiac shock, they had multi-vessel disease, and they were randomized to either treatment by only culprit lesion at the time of primary PCI, followed by stage PCI of the other non-infarcted artery, or immediately multi-vessel PCI. In the same sitting was the patient was randomized or to immediate multi-vessel PCI. And the results at 30 days established for some time to come, that the culprit lesion only PCI was superior to multi-vessel PCI among patients with acute MI and cardiac shock. These patients at that time, after 30 days, those patients who underwent only PCI of the culprit artery, they fared as far as the mortality was concerned at 30 days and as far as the renal replacement therapy was concerned. At the end of 1 year, it was found that these two groups did not differ as far as the mortality was concerned. But at the same time, it was observed that the rates of rehospitalization for heart failure, as well as the repeat revascularization, was higher in the culprit lesion only PCI group. So, keeping in this mind, the robust data which came out from the culprit shock trial, it was the opinion of the 2017 ST elevation MI task force, that in patients with cardiogenic shock complicating ST elevation MI, primary PCI should be restricted to the infarct-related artery only. This further confirmed that infarct-related PCI is the way to go in those patients who present with cardiac shock. And immediate multi-vessel PCI should be customized. The multi-vessel PCI to the non-infarcted artery should be done in those patients where infarct-related artery is difficult to identify. That's one situation. Or in those patients where we find a very severe flow-limiting non-IRA stenosis, and which is subtending a very large myocardial area. And the patient still is not improving after the primary PCI to the infarct artery has been done. So, in effect, even after the culprit shock trial, the strategy was left slightly open by the fact that the culprit artery PCI is the way to go, and multi-vessel PCI should be attempted only in certain situations. As if this was not enough, then came the Camille NIH registry. Mind you, this was an NIH registry in which the patients of cardiac shock with acute coronary syndrome, they were randomized to either undergo IRA only PCI or multi-vessel PCI. And the results stunned everyone. It was seen that multi-vessel revascularization for non-IRA stenosis in patients with ST elevation MI with cardiac shock showed a significantly lower risk of all-cause death compared to RIA only PCI at 1 year. Now, this was at quite a contrast with the culprit shock trial. The results were definitely different. They were contrasting to each other. But if we have to understand why they were so, we have to see the trials in the right perspective. The culprit shock PCI, the patients which were included in the trial, had the patients who had both ST elevation MI as well as non-ST elevation MI, which have got different implications. Moreover, those patients who had undergone only culprit artery PCI in culprit shock trial, they had undergone stage PCI to non-IRA also, maybe at a later date. Again, those patients who had undergone multi-vessel PCI in the culprit shock trial, many of these patients also had CTO, which were also tackled at the same time. We understand that the tackling of CTO in a situation of cardiac shock, where the patient's hemodynamics are already challenged, it may be having its negative role, and these patients must have confounded the variable. I mean, they must have played a confounding role in the results of culprit PCI. On the other hand, those patients who were included in Kamir NIH registry, these patients who were having multi-vessel PCI, this group had two groups of patients. One was that group who underwent multi-vessel PCI in the same sitting as the primary PCI, and other group of patients who had multi-vessel PCI in a staged manner, and they were clubbed together. So what I want to impress upon is that though the results of culprit shock and Kamir NIH, they appear quite contrasting, but still they fail to lead us to any reasonable conclusion by which we can say, well, this is that the rule is now clear that only the culprit artery should be tackled, or multi-vessel PCI is the rule of the thumb for patients of acute MI with cardiac shock. And 3 years outcome of Kamir NIH also showed that those patients who underwent multi-vessel PCI, and if the revascularization was complete, the results were better than in those cases where the revascularization was incomplete. Till now, the role of MCS, that is mechanical cardiac support, was not clearly evaluated in either the trial, the randomized trials, or any of these registries. To address to this emerging role of MCS, the National Cardiogenic Shock Initiative has been devised, planned, where in the patients who who had only single coronary artery disease, they underwent PCI and had 75% survival. Importantly, those patients who had multi-vessel coronary artery disease, they were randomized. Mind you, all the patients had undergone mechanical cardiac support implantation early on in their management strategy. And those patients who had multiple coronary artery disease, out of this, those who underwent culprit artery PCI and the multi-vessel PCI, the results were similar. And what is the difference in this initiative versus the Kamir and the culprit shock trial is that all these patients had underwent MCS placement early on using an MPLA device. And the survival was similar whether the patient underwent culprit artery IRA, the IRA angioplasty, or the patient underwent multiple vessel PCI in the same sitting. The results of mortality, as far as mortality was concerned, and AKI were similar. So integrating or taking into consideration of all what we have been discussing over the last 2 minutes, a reasonable algorithm can be planned as such of those patients who come to us with acute MI and cardiac shock, assess the patient clinically, which is the most important part of the management of these patients, try to preempt the diagnosis, and so that the patient can be stratified accordingly, risk stratified accordingly, stabilize the patient, taking care of the hypoxia and acidosis and managing of the hypotension. If the cause is mechanical complication, obviously the patient has to be sent for surgery. And if the patient has been diagnosed as cardiac shock, we have to consider an early MCS. But the cautions against MCS is that if the group of the team which is dealing with the patient is having low level of experience with dealing with, tackling with the MCS, or the anatomy, that is vascular anatomy for access, is not appropriate, or if by any chance the MCS placement is going to delay our perfusion therapy, in that case, we can go ahead with the angioplasty straight away, revascularize the culprit vessel, and verify the stability for transfer to ICU after that. So I think the take-home message for me is that from now on, We have been talking about door to needle time, which decides the mortality, the long-term results of the patients who come to us with acute MI. The latest emphasis now is on for door to unloading time. And more and more patients of acute MI with cardiac shock will be benefited by use of mechanical cardiac support, by unloading this group of patients. Once we unload, once we rest the myocardium, the revascularization will be better and producing better results. Whatever the strategy we may employ from there, whether it is a culprit artery strategy, treating the culprit artery only, or the multivessel angioplasty to be done at the same sitting. As of now, 2018 guidelines, they suggest that emergency PCI of the culprit artery is the established strategy for those patients who come to us with the cardiac shock. And in cardiac shock, routine revascularization. Mind you, the routine revascularization of non-IR lesions is not recommended as of now. But this has to be customized depending on the situations, which I've already emphasized upon in last few minutes. Those patients who still do not improve, who still have evidence of ischemia after taking care of the culprit artery, or where the IRA is not clear, they can be subjected to multivessel bleeding. I thank you for kind attention, please.
Thank you very much, sir, for that very excellent and lucid talk. And I think it has educated us a lot, because one of the, just a routine thinking or routine practice adoption is that if a patient with STEMI presents with cardiogenic shock, people or an intervention cardiologist can attempt a non-IRA vessel as well. But you have clearly highlighted the routine non-IRA vessel is a class 3 indication. So let me ask questions from first intervention cardiologist, then others. Dr. Govind, do you have any questions for sir or any thought process? Govind? Dr. Pavan?
Sir, I would ask sir, how strategize they for the stage procedure these such kind of patients when they go for non-IRA interventions?
So, sir, Govind is asking, how do you stage such patients, or what is your strategy to treat the non-IRA lesion in patients who presented with STEMI and cardiogenic shock? Is that correct, Govind?
Yes, sir. Yes,
yeah.
Exactly.
So I mean, again, this has again to be customized, and if the patient continues to be doesn't improve after the tackling of the culprit artery, the non-IRA arteries have to be addressed to in the same hospital admission, in the same index hospital admission. And if the patient improves after that, then obviously we treat them accordingly, as we treat the other patients of without cardiac shock, meaning thereby that if the patient continues to be symptomatic after the patient has been discharged, or he has any evidence of ongoing ischemia, or any manifest evidence or any inducible evidence of ischemia, then he is treated for taking care of the non-IRA vessel. So that is what it is.
Dr. Pavan?
Good evening, sir. Sir, I think it depends on the severity of the lesion of the other vessel,
yes.
other than the artery also.
Yeah.
So that also decides the timing of
absolutely. So I mean, if it is a very flow-limiting lesion, severely flow-limiting lesion, if it looks to be very unstable, very ugly lesion, and if it's tending to a very large area of myocardium, then it has to be addressed. The only thing is that the chances of renal replacement therapy and LV dysfunction, you may aggravate the LV dysfunction if we are trying to do it in the same sitting. So the scenario has to be seen in the light of the patient clinical scenario, as well as the hemodynamics of the patient. It has to be customized.
Thank you,
sir. Dr. Dinesh, can you hear us? Dr. Dinesh, are you there? So, Dr. Dinesh, you work in a medical college. I think.
Yeah.
So, any questions or anything which you want to highlight?
Good evening, sir. Actually, we are in same scenario, medical college. Are you doing routinely primary PCI in SMS, sir?
Dr. Ravinder, would you answer that?
So I think there are so many things which enter into the logistics of doing a primary PCI. But let me ask you this question to both of you, Dinesh, Dr. Dinesh sir and Rajiv sir, and maybe Dr. Pawan and Govind can also add to this question. Sometimes we come across a scenario where patient has, presented to us late, like he's between 24 to 36 hours, anterior wall MI, STEMI, cardiogenic shock. You do an angiogram, now his LED is 100% occluded. Now, for me, it is a big confusion because I know that if I revascularize, still that patient is not going to survive. The myocardium might not recover, but the guidelines still say up till 48 hours. So how do you tackle such a scenario? And it's a routine thing which we see in India because, patients are not educated. They would present to us very late and now they are in cardiogenic shock. So, sir, how do you tackle such a scenario? Would you still go ahead and do a PCI, or you would educate the family about future course, or how do you tackle?
Can I answer? Yeah.
Yes.
I think the first question which Dr. Dinesh was asking regarding PCI, primary PCI. Yeah, it's a foregone conclusion that we have been doing primary PCI over last, I think, probably 10 years or so. Whatever is the hour of the day, the primary PCI has been done. In our institution, and so many people have passed out from there, knowing about this fact. Coming to the second question, yeah, this is a very difficult scenario, and afraid because the guidelines, the pressure of the guidelines.
Yes.
We have to take this patient up for angiogram, and because at that point of time when you have taken the patient inside the cath lab already, and you realize that the only LED is blocked, whatever is the benefit we can give, the benefit of doubt probably can be given to the patient, and in the minimum amount of dye, because if there's the only single vessel which has to be tackled, probably we can do it safely also. The scenario may be more difficult if the patient has got blocked LED and along with the other arteries also blocked. So then it's a very difficult situation. But otherwise,
yeah.
If
So
the patient is hemodynamically unstable, then we can go for
Pawan, Dr. Pawan, let me ask you, would you put a balloon pump in such a patient, or you would just go ahead do a primary PCI?
So that is what I am answering. If the patient is hemodynamically unstable, then I think we will fix the lesion. And if the patient is hemodynamically stable, if the vitals are stable, then we can go for viability assessment also in case of 100%.
So the question was already like patient presence with cardiogenic shock.
Okay.
Yeah, so
we can go for a balloon pump.
Balloon pump with PCI? Govind, balloon pump with PCI, without balloon pump?
Definitely, I will go with the balloon pump PCI. But another thing here is I would highlight that all the Western guidelines mention that IABP either it is have no role or it is class 3 indication in the cardiogenic shock. But in our practice, we usually see that IABP we usually put and patient recovers with it. So it is kind of a practical experience is kind of contradictory with the guidelines.
Me and Govind, we both are from SMS, and it's a very high volume center, routine primary PCIs, IABPs in the middle of night. But somehow the guidelines were always against balloon pump. Sir, what would you recommend to all the new, young audience and people who are listening? Cardiogenic shock, should we put a balloon pump or should we stick to the guidelines?
Ask me?
Yes, sir.
Anybody? Okay.
To you, sir. Rajesh, sir, to you.
Okay. Guidelines may be not true for a particular patient.
Yes.
So for that particular patient, if we lose that patient, or for him, for his or her family, he is not a statistic. So I think if that helps a particular patient, it makes our life easy for the patient as well as for the teaching doctor. So if available, if it can be put very easily, one can go for it. Whatever the guidelines say.
So
guidelines are simply directives.
Yes. So let me ask this question to our cardiac surgeon, Dr. Buddhaditya, because cardiac surgeons believe in balloon pump a lot. Dr. Buddhaditya, can you hear me? Dr. Buddha? 2 questions to you. 2 questions. Number 1, role of CABG in acute MI cardiogenic shock. Number 2, what is your thought about using IABP?
Acute cardiogenic shock, if there is a mechanical problem, as in the patient is presented in frank pulmonary artery, pulmonary edema, or he has a VSR, or he has a flail mitral leaflet and he's presented with the associated CAD, then my preference is to rush to the operating room at the earliest. I mean, there's a lot of data to show that the early interventions, the patient tend to fare better than in terms of stabilizing them on mechanical circulatory support. The second thing which we have to realize is, as much as we talk about things, ours is a resource limited country and resource limited setup. So we have to take into account the fact that we are very limited in the mechanical circulatory support devices which we can offer to these patients. Now, the easily available and the more affordable device is the IABP or the balloon pump. So I think that the mainstay, as much as we may agree or disagree about the long-term benefits, I know the shock trial did not show that comprehensively balloon pump, but in the acute case scenario, when you are limited to inotropic support, I think the balloon pump can be a very handy tool. And as a surgeon, again, I would like to reiterate that early intervention would probably be the buzzword. And then in terms of stabilizing. So fix the problem first and then get into. If it's an elective, let's say acute MI, if it's an anterior wall MI and the patient is reasonably stable, unless he has a very, very critical lesion, which is like a typical, very critical left main or critical, signs of ischemia ongoing, we would prefer to wait and stabilize those kind of patients. If it's an inferior wall MI, I'm probably a little more encouraged to go in and operate on those patients because they tend to usually do well. There's enough data. Yeah, there's enough data also to show that if it's an acute MI, and you actually don't look at the patient in isolation, numbers in isolation, you look at the patient overall. So if his presentation is in the fact that he presents with signs of acute inflammation, with a raised creatinine, with a TLC that's very high, who's in some sort of a cardiogenic shock, then probably, and he's holding on, all right, and the lesions are tenable to wait, then I would probably wait and stabilize that patient before rushing to the theater. It's an inferior wall MI, and the patient seems to do reasonably all right, or there's a problem, I would tend to operate him early. So acute MI, we tend to wait for 7 to 14 days.
Just a last question, because we see this routinely from the cardiac surgeons that troponins are elevated, we would not like to operate. So what is that magic number, or how long do you wait for the troponins, or would you wait or not wait at all?
Well, you know what? So if it's
so let us say patient is not a STEMI, patient is like a non-STEMI, ACS, left main, critical TVD. Would you wait for troponins to come down, or would you go ahead and operate?
There's there's never a one factor which determines the operability of the patient. I mean, no surgeon would bank or his surgical on one number. So it's the total picture. The patient seems to be unstable. Anatomically, he has critical lesions, then he deserves surgery. The outcomes of whatever the labs or biochemistry may show comes later. But if the patient is in that situation, you're weighing against waiting on that, then of course, I think these markers can help the decision-making process. For example, if somebody is otherwise reasonably stable, he's got an elevated troponin, he's got an elevated CPKMB, it's an anterior wall MI, there is some degree of MR, there's some degree of pulmonary edema, there's some degree of oliguria, the creatinine's a little high, I or any surgeon probably would want to stabilize him and wait. So yes, like I said, it's not etched in stone, but yes, we do look at those markers to give us a sense of which direction we need to proceed.
That was a very important insight from the cardiac surgeon's perspective, because the thought process of a cardiologist and cardiac surgeons are a little bit different. So let me ask one last question to maybe Dr. Kailash, and then we can go on to the next talk. Dr. Kailash, so when you have these borderline patients, blood pressure 110, you're trying to deal with a STEMI or a non-STEMI, and would you prophylactically connect NORAD like an infusion of 1 or 2? I see in many labs that you would prophylactically connect inotropes to the patient. Do you do that in Italy or no?
No, sir. This is if there is borderline, then we don't take on the vasopressors. If it is looking like 100 is not, it depends on the clinical scenario of the patient. If patients, we are going to for angioplasty and there is blood pressure is 90 or maybe 100, but clinical scenario patient is tachycardia is there, and then we will prefer to take it on the mechanical ventilation, support device, mechanical support device, rather than the vasopressors. that if the patient is in cardiogenic shock, we prefer to take on the IABP first if it is not critical, not very high risk. If there is very high risk patient, then prefer to go for impeller.
Okay.
But initially we cannot go for, we don't go for NORAD.
In the Western world, they use IABP?
Yes, definitely they use a lot. This is like, I say that this is like thrombustor. In the guidelines, thrombustor is not accepted, but still there, you already have seen that there is a lot of role of thrombustor. Always we use thrombustor.
I think that was a fantastic comparison which you gave, Kailash, that thrombustor trials failed, but we always see that thrombustor sucks out the thrombus. But one last thing which I would like to highlight here, sometimes, we would choose 30, 35, 40. In my own opinion or in my own practice, I would go with the largest size balloon pump. The reason is more the blood volume you displace, better the end organ perfusion and more the suction power and more the coronary perfusion pressure. Sometimes choosing a 30 mm, 35 mm might be too small for a particular patient. So I think that was a very interesting talk and discussion, and we have learned that we should not try to have a lesion-based approach. We should have a patient-based approach. What I mean to say, you have done a culprit vessel, now you see another non-culprit lesion, don't go ahead and put a wire and put a stent in all of them. You should look at the patient in total, and that is what Sir had highlighted. So instead of having a lesion-based approach, have a patient-based approach. And the culprit shock trial clearly showed that 25% of patients had CTO. So we should not attempt a CTO non-IRA in the same sitting. The important thing which we know from the CTO trials, a failed CTO has poor outcomes compared to a non-attempted CTO. So I think we move on to a very important talk. The next talk will be given by Dr. Buddhaditya Chakravarti, who is our director of cardiac surgery. He's an excellent and a prolific cardiac surgeon. He's trained from AIMS and then did his fellowship from Harvard and Mayo Clinic. He did the first heart transplant in Rajasthan, and he has been actively involved in all cardiac surgeries as well as the ECMO program here. And the ECMO has even reached to the common man. Now a patient would come and, sir, can I get ECMO because somebody is suffering from, some relative is suffering from COVID. So we can also have a small discussion with inputs from Dr. Suresh Rao, how the ECMO is helping COVID patients, or is it helping, or is it not helping at all? Dr. Buddhaditya Chakravarti is going to talk on ECMO and LVAD for cardiogenic shock, identification, timing for initiation, escalation and de-escalation of therapy. Dr. Buddha, over to you.
Good evening. Am I audible? Can you see my screen?
Yes, we can see your slides and you are audible.
Great. Thank you very much. It's indeed a huge pleasure to be in such august company. And being a cardiac surgery, getting a foray into the cath lab with our devices is something which every cardiac surgeon is probably looking forward to. So this is a great opportunity. Thank you very much. After all those excellent discussions from such esteemed speakers, I think my work has been made significantly easy. You've laid a wonderful edifice for discussion about mechanical circulatory support. And I'm going to focus on the use of ECMO and temporary LVADs in patients of cardiogenic shock. Now, there are three key messages which I want to highlight before we begin this talk. The first being, cardiogenic shock is a multi-system disorder. We have to realize that other than treating the core pathology, which is cardiac related, we also have to take cognizance of the fact, and this has been highlighted ad nauseum by every speaker on this forum and everywhere else, that it's a pan-systemic involvement, and you've got to be very cognizant of the after effects of the cardiogenic shock on all the systems, whether it be the brain, the lung, the liver, the kidney. And the whole concept of mechanical circulatory support stems from the fact that when you are dealing with a pan-systemic disorder, you need all the help in getting these organs to function optimally so that you lay the foundation for recovery of the core pathology. Unless you do that, then it becomes a domino effect. The affliction of one organ leads to the affliction of the other, and soon we are embroiled into a multi-system disorder. The second most core important message for any kind of device, and that holds true for anything in life, is timing is the key. Now, I understand that given the limited resources that we have and the constraints about, the economic constraints, the lack of understanding amongst public, pushing for mechanical circulatory support can be a bit of a challenge. Also, the bigger challenges are that not all centers are equipped in terms of the hardware and the technical capabilities and the logistics of manning these devices. But as Dr. Rao and everybody else before me, Dr. Bhagaratta, has very pointedly emphasized that, you can't wait long enough. Dr. Dinesh made it very clear, I particularly that word in extremis, the stage E of cardiogenic shock, where the patient is in florid heart. That's the point where, we think mechanical circulatory support should be initiated. But with experience and with a little bit of, our insight, which we have gained over the past few years, it's become very clear that the quicker the decision to bridge these patients onto the MCS are taken, the more preserved the patient is, the better are his chances that he will survive and sustain the MCS delivery. And the third most important point when you're contemplating a device is you have to have a clear concept in your mind as to why are you doing it. It's a different situation that somebody is arrested and you're rushing to sort of get a blood pressure on that patient and you're scrambling with whatever devices you have. But in a more elective scenario, or when you have a patient in an ER and you have some time with you, it's very important to contemplate as to which direction do you want to take this treatment forward, and how will mechanical circulatory support facilitate that. You have to have an exit strategy. There can be only three options primarily. One, you can hope that the patient recovers to the point that he does not require anything else. He can, just sustain himself on maybe mechanical ventilation, inotrope, and gradually be weaned off that. And that is, in most likelihood, the most common scenario in our situation. The second situation is where you think that this patient can be transitioned into more durable and enduring device like a ventricular assist device. And these devices come at a high price. They come with their own subset of complications. And they also come with the challenge of logistics and learning with the organizational skills. And the third strategy is, if we can tide over the acute phase using these MCS and then tide these patients over to something like a transplant. So the caveat is that you just can't go in and sort of put in a device. You have to have a clear exit strategy from that. Which brings me to the use of ECMO. Now, when we're talking about ECMO, we all know that there are two kinds of ECMOs. And we talk about the veno-venous ECMO, which has gained a lot of attention during the COVID era. And then there's the VA, or the veno-arterial ECMO. Now, when you're talking about cardiogenic shock, you have to remember that it's the VA ECMO we are talking about, because the VA is responsible for supporting not just oxygenation, but also the circulatory system. If you talk about VV ECMO, then it's primarily a support for your respiratory system. Now, when I go to talk about ECMO, I'm going to highlight these very headings under which we're going to discuss, and I'll get started right away. I'll try to keep this talk less and less, data intensive, so that we just get a concept about how and when these devices can be used. So patient selection, like highlighted by all the previous speakers, profound cardiogenic shock. It could be acute, or it could be a decompensation of chronic cardiac failure. It could be used in an ECPR device in cardiac arrest, biventricular failures, hypoxemia, various indications. Now, whenever you have a patient like this and you are contemplating device, it's most important to factor in the things which I have mentioned below. You have to, like I say, have a preemptive vision as to which way are we going to take this treatment ahead. What is going to be our exit strategy? So your decision on device would also depend on the time of initiation of these devices from the onset of the problem, the age of the patient. Ground reality, these are expensive devices. There's a lot of money involved. There's a lot of resource involved. We don't want to wet it away. So you try and pick your patient who's probably the best suited for survival with these devices. And probably, somebody who's 75, 80, and it might be unfair to say that, these patients don't deserve all the, but the fact remains that these patients tend to fare poorly on the device. So you have to weigh in all the factors of, benefit versus risk in these patients when you make that decision. What is also important is, other than the timing of initiation, the patient's general condition when you're contemplating device initiation. What are his renal parameters? If you have somebody who's on a ton of constrictor, industrial doses of constrictors, his urine is tapering off, his liver functions are already deranged, his cognitive functions are in question, then probably he may not do very well when you put him on an MCS. The hope that the MCS will reverse all these pathologies is not going to be holding a lot of ground. As and when we gain more in experience, we've realized that the golden hour is when the kidney is functioning all right. Maybe, not optimally, but not completely shut either. The liver functions are not completely out of whack. The patient is neurologically intact. He or she does not have any systemic coagulation parameters, because you have to also realize that maintaining these patients on device can be also a bit of a challenge. Now, cannulation strategies, when you talk about VA, it's either peripheral, in which case, if patients come in an acute shock state, you do a peripheral cannulation. Now, the peripheral cannulation can be through a cut down, or it can be through a percutaneous Seldinger technique. In our practice, most of the elective cannulations which we do have easily been percutaneous. But in a shock state, if you have a patient in the ER who's arrested, probably a cut down can be a better guide, because you're going to shove in big cannulas into the arteries. And unless you're sure that you're going to the right plane, then probably, it's a little dangerous to sort of push in a cannula through percutaneously. So in an acute shock stage or collapse state, you can cannulate the femoral artery. Sometimes in a more elective setting, you can choose to dissect the axillary artery and sew a graft onto it. There are some centers which advocate sewing a graft onto the femoral. It's a chimney graft, because they are also concerned about distal limb perfusion. But like I said, again, you choose your setting and then choose the surgical decision. The drainage is usually through a femoral vein. If you are in a post-cardiotomy or a cardiac OR setup, you're already cannulated. It's the aorta, the right atrium, or it's bicaval cannulation. What are the kind of cannulas? Without getting too technical about it, the femoral arterial cannulas and the venous cannulas, the sizes can vary from 17 to 24. Different companies have different codes. You can choose one of them and work with it. Do remember the important concept that it's not necessarily important to push the largest cannula in for the maximum number of flows. We do understand that a patient's certain body area demands a certain degree of flow support, which needs to be supported. So the adequate size of cannula, which is just about right for the patient, is the right cannula for the patient. Because the larger the cannula, the larger the chances of complications while introducing that cannula or keeping it in. About the femoral venous cannula, just wanted to get a word out there that there are actually 3 different types of venous cannulas, which you probably should know. One is, when you do is use it for a bicaval cannulation percutaneously, which is what we use conventionally for VA ECMOs. You have holes at the tip which are draining the SVC. There's a length of about 8 to 10 centimeters, and there are holes which drain the IVC. And you put it through the femoral vein and guide it up, echo guided. The other kind of cannulas which are available and which are used primarily for VV ECMOs are cannulas which have got multiple drainage holes at their tips. And then the third cannula which is available in the market, which are the flex cannulas, which have holes only at their tips. And these are usually the inflow cannulas into the patient in VV ECMOs. So when you're choosing your cannula, you have to know the difference between the 3, and you have to have almost all sizes. So venous cannulas start from anything from 23 to 33. You have to have an average optimum size available in your shelf, because sometimes getting these cannulas, especially in era today, can be a bit of a challenge. Now, when you talk about cannulation in a VA ECMO, one very important concept is the Harlequin syndrome. And this can actually impact the oxygenation and circulation in a patient. Now, what is the Harlequin syndrome? I'm sure a lot of you have an idea, but I'll just go very briefly on this. Basically, when you have a cannula in the femoral artery, it is pushing blood, which is 100% oxygenated, through the femoral, and this blood is traversing retrogradely up your aorta. At the same time, the blood which is returning to your left ventricle is deoxygenated, slightly deoxygenated, or maybe more deoxygenated, depending on the pulmonary condition. In all probability, if your patient has pulmonary edema or has an associated lung pathology, then the blood which is returning to the left side is deoxygenated. Now, depending on how hard the LV is ejecting, the blood or the deoxygenated blood from the LV and the oxygenated blood from the femoral artery cannula are going to meet or interface at a certain point. If the ejection is strong enough that that watershed area is beyond the level of the left subclavian, then what is effectively happening is that the brain and the blood vessels to the neck, particularly cerebral circulation, is getting affected by the deoxygenated blood. And the oxygenated blood which you are pushing in is not adequately reaching up to the brain. At the same time, then, the patient can have deoxygenation of the head and blood vessels, neck vessels. So one good way to look at it is, the right radial artery saturations, and you can monitor that. The one very easy way to get a sense of where your watershed area is looking at the pressure tracing from your radial. If the pressure tracing, you see a very profound pressure waveform, then probably the ejection is low. If the pulse pressure is very low, then probably the watershed area is closer to the aortic valve. And what is a harlequin? Just for all of you who wondered what that word was, we just had a fit. Now, one very important concept about the VA ECMO is to understand the physiology. Now, the VA ECMO, of course, offloads the right system. It drains the right atrium, it offloads the right system. It will decrease your LV preload. But what you have to realize, and this is the most important concept in using a VA ECMO, is that there is no offloading of the left ventricle. All the blood that's returning to the left ventricle, either it is through the Thebasian veins, it is from the pulmonary veins, which are coming from the lungs, the blood which is coming from the lungs. If there is any degree of AI, all of this will increase the LV-EDP. And that is not something which you want in a sick left ventricle. If your idea is to decompress and rest the ventricle, then an increased LVDP is not going to help. This also leads to LV distension. How do you take note of this? There are several methods to do it. I can go into the details, but a good way to do it is look at it echocardiographically. You can look at the opening of the aortic valve. That can give you a sense of, if your LV. It's difficult to look at, the windows are never good enough transthoracically to see if your LV is actually distending. But if you look at the ejection and at the aortic valve opening, you get a sense of how full your LV is. And what do you do if your LV is full? So these are the various modalities you can use to offload your LV, something as empiric or simple as increase the ejection, but you use some inotropes, get the contractility going so the LV ejects more. Second option is use vasodilators, so that helps the ejection better, the afterload reduction, the LV empties better. You can use an IABP. So in all practical reality, in ground reality, whatever theory we discuss, everything aside, in ground reality, patients of VA ECMO, most of them end up with an IABP so that we can offload the left ventricle effectively. There are other more theoretical discussions like balloon atrial septostomy. This is usually done in pediatric patients who have been put on ECMO. It's easy to do on the bedside. You can have a cannula which is connected into the left atrium and transeptally, and which drains into the venous side of things. And of course, if you are surgically open, then it's a more simple affair. You can put in a superior pulmonary vent. You can put in an apical left ventricular vent. You can wire it to your venous system and sort of drain the left side of the heart much more effectively. And there's another concept of, now which is gaining vogue is introducing the impella, because, the impella is an excellent device to offload the left ventricle. So in conjunction with the VA ECMO, you can use an impella and help that to offload the left ventricle. And that's gaining a lot of vogue in today's era. The other important thing is, 12 to 22% of these patients on VA ECMO will have some degree of limb ischemia. You got to need to address that. The way to do is introduce an antegrade cannula, a 6 or 8 French cannula sheath into the femoral artery, and you wire the arterial limb to the side channel and perfuse that limb. The other option, like I said, in a more elective setting, is sew in a chimney graft to the femoral artery and perfuse through it so that your large cannula is not obstructing the femoral artery. Anticoagulation strategy: when you initiate, please do be cognizant of that fact that these patients can be very sick and can have a lot of coagulation derangements when you are initiating ECMO. So a good idea is to get an ACT at the baseline before you trudge them with heparin. A lot of times these patients have been loaded in the cath lab with a lot of antiplatelets, so they tend to bleed a lot, especially the ones on VA ECMOs. So you need to sort of be careful when you administer the heparin. It suffices to initiate the VECMO at an ACT of anything from 180 to 220. And as you settle down to the run, you keep your targets of ACT lower, about 160 to 180. This is usually affected by running a continuous heparin infusion, unfractionated heparin infusion, titrating the ACT every 4 or 6 hourly. The other options to titrate your heparin requirement is to monitor APTTs, and some better centers, you can monitor the anti-factor 10As. Now, what are the complications? Of course, the major complications are coagulopathy, thrombosis, limb ischemia, sepsis in our setup specifically is a huge challenge, and neurological events. So this is the ELSO data, which is the apex body for all ECMO patients. And the ELSO data, and this publication is from 2015, so there'll be some newer data available. But across the board survival for device-related ECMOs is close to 41 patients. So you're salvaging 4 out of every 10 patients, which is not a bad deal at all to start with. And if you look at some of the data in detail, or if you look at it more closely, then you see there are 2 or 3 things which are very, very pertinent. The first thing is the median days of ECMO. So if you need to put an ECMO and the patient for less than 4 days, then probably your patient was too sick and he didn't make it beyond the 4th day. The best results are for patients who sort of made it between the 4th and 7th day. But as long as you sort of keep running the ECMOs, the VA ECMOs for more than 1 week, then the chances that he or she will recover out of an ECMO starts to get slimmer and slimmer. And so if you look at further data, so at the first week for non-cardiac patients, medical non-cardiac illnesses which required VA ECMO, almost 53% of them survived. But when you extrapolated that to the second week, it dropped down to 42%. And as we went along 1 week further, then the chances of survival trudged down further to 25%. In our own experience, we've had reasonable success with the VA ECMO setting. What we have realized is the quicker we get the patients off VA ECMO, of course, not at the cost of compromising his hemodynamics, the better the patients have fared. So our survival for VA ECMOs are close to 70% in my personal experience. But the quickest we have withdrawn an ECMO has been within 48 hours. And the longest we have kept is probably more than 7 days. Whenever we have kept these patients more than 7 days, we've run into problems in maintaining these ECMOs. The best results have been between day 2 and day 7. That also brings us to the second kind of modality or option available, tandem heart. It's more of a cardiology's domain, so I'm going to restrict myself speaking not too much on this. So I'm going to skip this one and directly trudge on to what is a VAD. Now, this device that you see in your screen, this is the workhorse for almost all mechanical circulatory support systems, including the ECMO. Now, this CentriMag is a wonderful device, and the key to this device is the pump. So the pump, the technology here, and then this CentriMag is device manufactured by a company called Revitronics. It's the pump here which holds the magic key. It's a maglev technology. It's a levitating pump in which there is absolutely the disc is suspended in a magnetic field and it moves frictionless. And so you can intuitively understand that if there's a device or a pump which moves frictionless, it causes less damage to the cells. It lasts longer. There's less heat production. And so there is, more enduring. This machine becomes more enduring. So this is the workhorse for a majority of the patients' devices all across Europe and America. This is a powerful machine. It's much more powerful than the ECMO machine. So how are the ECMO machines and the Levitronics different from each other? It's in the pump. The ECMO has a rotor pump. This one has a magnetic levitating pump. If you wire in an oxygenator and a filter to this can function as an ECMO. If you remove the oxygenator, if you have a line filter and blood drainage, this functions as a VAD. The ECMO can support circulatory flows, the machine up to about 7 liters. This can support flows almost up to 10 liters. The pressure head that this device can generate is significantly more, so it's a more powerful pump than the ECMO rotor. And in Europe, this is certified for use for about 30 days. Indications practically remain the same. You can also, like I said, double up and use this machine as an ECMO. Now, you have to realize this concept, and when we talk about ECMOs, in the COVID era, it's been very commonly heard that the patient is being kept on ECMO for 20 days, 30 days, and he survived. What I want to highlight here is patients on VV ECMOs are much more amenable to be managed easily than patients on VA ECMOs who have cardiac involvement. So please don't equate the two ECMOs or the data from the two ECMOs. They are vastly different stories altogether. So indications for the VADs, post-cardiotomy, graft failure, refractory heart failure, RV failure, or a bridge. Now, depending on the position of the cannula, most of these are open-chested patients. If you're draining or you want to decompress the left ventricle, you put a cannula into the LV apex or the left atrium with purse string sutures, and you put the outflow cannula is through there, and the inflow cannula comes back into the aorta. You can directly cannulate, or you can have a graft on the aorta. For the RVAD, you cannulate the right atrium and the pulmonary artery. For the BiVAD, you use both. There are a lot of percutaneous methods. I won't say exactly percutaneous. They are minimally invasive methods of implanting these temporary LVADs. And like I said, you have to understand there has to be an exit strategy. Either you are aiming for bridge to recovery or a long-term VAD or a bridge to transplant. And just to give you a snapshot, there's some data from the NHS in which, patients who are post-cardiotomy, 75% of them survived this. But look at the mean support period. The range was from 31 days to 167 days. And do remember, I just told you, Europe has just certified this for 30 days though. So these machines are enduring. You can keep these patients on for almost a month, hope that they get better. But if they don't, then most of them need to be transitioned on into a more enduring VAD, or they need to be bridged into transplant. The overall survival for these patients at 1 year was 54% across the board. And then you transition them into more enduring or long-term or intracorporeal VADs. On the left, the VADs have also over time sort of shown more and more promise. The devices become smaller, less and less complications. We began with the HeartMate series of devices on the left, the Jarvik on the right, and we have ended up with the hardware, which is more simpler, more smaller to implant. And these are, as destination VADs, or these are ultimately transitioned into transplant. Of course, there was a sad news that the hardware now is being sort of withdrawn by Medtronic because there's a lot of complications which are stroke related. These devices have a story of their own. I don't think there's time enough for me to deliberate on that. With that, thank you very much for all the attention. I hope I've done justice to this hugely important topic, which is the way to the future. Thank you.
Dr. Buddhaditya, thank you very much for that great talk. So I was just thinking I'll finish my talk as well, and then we can have a discussion on ECMO LVAD. I will not take too long. I'll just try to keep it very short. So let me go ahead and share my screen. So Impella for cardiogenic shock. Can you see my slides?
Yes, please. Carry
on. 55-year-old male presented to ER with chest pain. While entering into the ER, collapsed, CPR started, intubated after 30 minutes of CPR, revived on 3 inotropes. Diagnosis is acute MI with cardiogenic shock. What we did not do in this patient is we did not do an ABG. We did not calculate a cardiac power output. Two important things. So we discussed all these things, very important, but we have to understand this cardiogenic shock syndrome. It is a complex scenario where it involves the heart, the lungs, the peripheral vasculature, the microvascular perfusion, which was highlighted so clearly by doing an ABG, then your urine output. So it's a spiral. So you need to intervene very early and treat the underlying cause, and not to intervene a patient who's presenting at stage E, because at that point of time, the patient might be futile. So again, clearly highlights a death spiral of a cardiogenic shock, where there is decreased cardiac output, decreased coronary perfusion pressure, more ischemia, end organ failure, and death. So it is very important to break this spiral at a particular point. These are the support devices which are available to us: IABP, Impella 2.5, Impella CP, Impella 5, tandem heart, and VA ECMO. Already discussed in detail. The only advantage which Impella offers, it is a continuous flow microaxial pump, and it can give a cardiac output from 2.5 to 5 liters and increases the coronary perfusion pressure and unloads the heart. These are how we can do a risk stratification for cardiogenic shock patients. It was clearly highlighted that there is actually no evidence for IABP, but we should still use it. And the reason we should use is because, as it was highlighted, that it still plays an important clinical role, and it is like a thrombuster which is used in STEMI patients. This is just one slide which I want to highlight. The mortality is also related to the number of inotropes being used. So if a patient is on 3 inotropes at maximum doses, the mortality is almost 80%. And this mortality, I would say, is not directly related to the vasopressors. That does not mean that you should not use these vasopressors. It tells you the severity of disease and the extent of cardiogenic shock which a patient is in. So this again, I would like to highlight the use of ABG in ER, where you can use lactate and a cardiac power output calculation using a 2D echo. And it actually gives us more insight into the disease of a patient, and it will help us to escalate or de-escalate the therapy. How does Impella work? Impella increases the flow, increases the mean arterial pressure, decreases the left ventricular end diastolic pressure, decreases the left ventricular end diastolic volume, and ultimately increases the cardiac power output. And remember, in the trials, the cardiac power output, or the CPO, was one of the better parameters to assess the outcome and prognosis of these patients. So how do you implant? So mortality of acute MI cardiogenic shock patients on short-term mechanical circulatory support, it is definitely lesser compared to patients who do not receive any support. So again, you identify a patient in cardiogenic shock. Identification, I mean, we learned from Dr. Rajiv Bagrata sir, as well as from Dr. Suresh Rao sir. It is an integration, remember, don't forget your clinical skills. It is an integration of clinical skills, the numbers, and the patient. So you need to tailor a patient-specific therapy, and you need to work on something called myocardial recovery, which can be based on use of an ECMO, Impella, IABP, and revascularization, whatever is available in the cath lab. This slides again highlights the important thing which was highlighted by Professor Rajiv Bagrata sir, the timing of implanting a Impella. There was something called an unloading. So which clearly showed that when the Impella was put in before a PCI in various registries, it clearly showed that survival was better compared to putting an Impella post-procedure. So this slide is very important. Adding an inotropes, more and more inotropes to a cardiogenic shock patient is like whipping the dead horse. So this is again very important, which was also highlighted by Dr. Ajay's talk. Sometimes we hear that first the patient needs to be stabilized and then an angiography will be performed. Let me highlight this important point. The way to stabilize a cardiogenic shock patient is actually to treat the underlying cause. So we should not wait for hemodynamics to become normal before you would do an angiogram in a STEMI cardiogenic shock. It should be done ASAP with use of mechanical circulatory support, whatever is available in the cath lab, but data clearly shows that Impella is better in such patients. So hours after the shock onset, more delay the presentation, higher the mortality. Here it clearly showed if a patient is presenting beyond 24 to 36 hours, the mortality is 86%. And when should a VAD be implanted? Again, it was clearly highlighted by Dr. Buddhaditya as well. If you are putting a VAD, once the metabolic acidosis has set in, there is something called irreversible cardiogenic shock death which is happening in the cellular level, and probably your intervention is futile. You don't want to put an impella, you don't want to put an ECMO in a patient who is cardiogenic shock, STEMI, 48 hours out of window period, and a dead myocardium. If you put it when there is hemodynamic problem, probably you are preventing the irreversible cardiogenic shock death. But the best time to implant a mechanical circulatory support or an impella is to prevent the cellular death. And this stage can be identified by use of CPO, numbers, the clinical examination, and ABG. So it's an integrated approach which should be used. So such a patient, again, the patient had CABG was turned down. We used an ECMO, IABP, ROTA, PCI of the left and bifurcation. Patient has actually completed 4 years. He came for a follow-up and is doing absolutely fine. This is how an impella looks like. We would put in from the leg vessel. It gives us a cardiac output of 2.5 liters, where a 2.5 is used. And then a PCI can be done. Revascularization can be completed for such patients. How to select a device? I think we can have a discussion. If you are doing a cardiogenic shock, the device should be able to provide a cardiac output of 4.5 liters and above. An impella 2.5 liter is actually inadequate for a cardiogenic shock patient. That would be wastage of resources if you are putting an impella 2.5 in cardiogenic shock. 2.5 is only for PROTECT PCI. In a cardiogenic shock, impella has to be 4.5 or 5 and above. I've also clubbed the cases, just one case, which I'm going to go, 37-year-old patient presented with fever, cardiogenic shock, severe LV dysfunction, 10 to 15%, SBP, systolic blood pressure, right heart cath, RV, RA, and PA saturation. Just two important things which I want to highlight. A patient who has cardiogenic shock, right heart cath is must. A PA capillary wedge pressure, a PA pressure is must. And we would always insert a PA catheter or just a multi-purpose if we are not able to, we don't have a PA catheter into the PA artery, which will help us to monitor the cardiac output by doing a mixed venous saturation and also monitor the pulmonary capillary wedge pressure. This is an example of a percutaneous impella which was inserted from the axillary artery, an impella CP which gave a cardiac output of 4 liters in such patients, and impella would be parked until the patient's LV recovers. How about cardiogenic shock? Patient multivascular disease, and impella would stabilize the patient. And I would not go into any details of the PCI. This would help us in completing the revascularization in such patients. This is a rotablator and a PCI was done to complete. Again, remember, this was an elderly patient who did not have any other option left. So, conclusion, mortality rates in acute MI cardiogenic shock have not improved in 20 years, which was clearly highlighted by the previous speakers. Protocol for leveraging best practices are required. Today, we are understanding the routine use of ABG, use of CPO monitoring, having a mechanical circulatory support in the cath lab, and establishing centers for the cardiogenic shock treatment. We plan, our aim is to develop a RHL Cardiogenic Shock Center, which will help us to treat patients who are in cardiogenic shock with the help of intervention cardiologist, cardiac surgeon, and intensivist. Thank you very much for your kind attention. With that, I would stop my presentation and would like to initiate a discussion on use of VADs. So I would ask the first question to Dr. Suresh Rao, sir. Can you hear us, sir? So Dr. Suresh Rao, we understand that you have the highest experience of using ECMOs and VADs in the country. Educate us about the ECMO during the COVID pandemic. I mean, these are tough times. What have you seen in your practice? What is the outcome? What is the average ECMO time? And how have these patients transferred from ECMO to lung transplant or?
Yeah.
Yes, sir.
This is what basically we use is venous ECMO, unlike for cardiogenic shock. So we use a 2 cannula technique. We insert the 1 cannula through the femoral vein into the IVC, the return cannula into the SVC or SVC RA junction. Now, when do you put the ECMO? First thing is we usually get COVID patients with the CT score of 25 by 25. They are on mechanical ventilation and their PF ratio is less than 100 with high airway pressures. Obviously, they will not last long. So such situations, we will put on VV ECMO. Now, once you put on VV ECMO, we can rest the lung. So we don't use high FiO2, we don't use high airway pressures. And unlike other cases of ARDS where the lung recovery takes 1 week to 10 days, here it takes longer time. So we have lung recovery after 1 month, lung recovery of 1.5 months also. So we need to give good time for the lung to recover. If you are looking at the outcome, it's around 30% of the lungs have recovered and we could wean off the ECMO and we could take off the tracheostomy. Of course, they usually takes almost 2 to 3 months before they could get discharged. And another 10 to 20% of the patients, we could do bilateral lung transplant. Now again, doing a bilateral lung transplantation is a huge challenge because they are on ECMO for almost 1.5 months. There will be a lot of bleeding, but still the outcome is around 60%. It's not as good as lung transplantation for ILD, but they have recovered. And another 40% of the patients, they keep on waiting for lung transplant, lungs are not recovering, then they will have an episode of sepsis or they will have GI hemorrhage or brain hemorrhage and we have lost them. So it is a useful technique and up to 1 month, I think you don't see much complications. Beyond that, we do see complications, but lungs can recover. So we found it useful.
Rajiv sir, questions from your side to Dr. Suresh Rao sir and Dr. Buddha.
I think the mention about the role of ECMO in the COVID patients, that is the probably talk of the common man also.
Yes.
I mean, these words are being used so frequently as commonly as maybe ivermectin now.
Yes.
So anyway, I mean, but yeah, I mean, the people from all over India look up to your center, Dr. Rao. We have been having some patients here who did not recover, and they were suggested that one should go to your center and maybe go for lung transplant. It's interesting, and probably for you also, it must have been a very interesting scenario where the role of ECMO has found a new setting. Is that right, Dr. Rao?
Yeah, exactly. So in fact, we used to have only 3 or 4 ECMO machines.
Yeah.
Now we have acquired almost 20 ECMO machines, and we have a 16-bedded ECMO ICU and the transplant ICU, which has got 10 beds. That also we have converted into almost ECMO or LVAD ICU.
So your experience on this and the other patients previously, the VV ECMO especially what you're talking about, is it same or it's different? I mean, the use of VV ECMO in these group of patients?
Yeah, definitely it is different. Unlike ARDS where the lung recovery happens in 10 days, here it takes a longer time. So it is a huge challenge. And meantime, one patient had GI hemorrhage and multiple times endoscopy, clipping done, finally got recovered. Then bleeding stopped and we could wean off the ECMO. One particular patient, in fact, we could wean off the ECMO. He was doing well, but then again he became sick. So we reinserted the ECMO. Again, he was on ECMO for 2 weeks. He recovered and we could wean off the ECMO. So you need to be, very, very, perseverance.
Optimistic.
Yeah, optimistic, perseverance.
Yeah.
You should not give up because that second patient who had second ECMO, all those doctors in the ICU said, sir, he's becoming sick, let us leave it. But I said, let us reinsert the ECMO, and he did well. Of course, the family was very supportive. They wanted to do the best.
So I think that's it. Dr. Buddha, you have some experience of doing ECMO in COVID patients. You want to tell us something and maybe highlight us important challenges in this?
Yeah, I think there are two very interesting trends which we could all see. One was during the first wave, when the patients came in, and obviously, as every unit, including ours, was a little hesitant or skeptical to approach these patients. They were older lot of patients, and they were sicker, and they did not hang around for a long time to be offered these MCS. The second wave was kind of different, in which there's a more younger population of patients afflicted, and so the ventilatory times were longer. And this time, obviously, our understanding of the disease and our approach to the disease had also changed. I mean, after the first wave and transitioning to the second wave, I think most hospitals adapted themselves very quickly to sort of formulate the protocols for COVID, and along with it, ECMO. So, I think most centers which have been doing ECMO, had a prolific experience during the second wave as compared to the first. Patients were younger, they were better preserved. But in our little experience, whatever we've shared, there are two key factors which we think was very important. The first remains the timing of initiation. Because what we've commonly seen is, the patients, they tend to get referred for these MCS pretty late in their course, after they have been on the ventilator for an extremely long time. They've probably cultivated some secondary VAPs or associated renal dysfunctions or liver dysfunctions. And when, sort of the pile is falling over, they get referred for ECMO. I think those patients do not do as well as those patients who sort of you pick up early and run with the system. There's general data or our experience too to suggest that if the intubation times to ECMO times are probably less than 4 days or 5 days, at best a week, then probably it is prudent enough to try ECMO on these patients. Because like Dr. Rao said, one has to persevere for a pretty long time on the ECMO with these kind of patients. The second thing which Ravindra, you and me have both been witness to this is, before you pick up a patient, it's very important to run through the entire checklist of how he is or how is he preserved before you initiate the system. Specifically, I would like to point out that most of these patients who've been on the ventilator for a long time have been on paralytics or have been on sedation. So it is difficult to assess their neurology. So we have learned our lessons the hard way. So I think what's most important is to develop a pre-assessment protocol, establish ECMO, and then run it as best as you can. Dr. Rao, to be very honest, our biggest problem in running the ECMOs have been secondary acquired infections. Most of the ECMO-related, the pump-related issues have been minimal. What we have encountered more commonly is sepsis, or that entire cycle when the patients transgress into renal failure and then they're septic. And we've had a tough time dealing with multi-drug resistant nosocomial infections all through the way. I wonder what's your experience? How do you maintain the sterility barriers? How do you do it in a 16-bedded ECMO? I think that must be one of the more overwhelming challenges. I'm very keen to listen to your experience about nosocomial infections in your unit.
I think you have pointed out the very important issue. We did have a problem with the infection in the beginning. We had a 10-bedded ICU where we used to use 4 or 5 ECMOs in one ICU. A lot of cross infections because, as you said, most of the people on ventilator, they get referred late, and they were insisting on continuation of therapy because we have a lung transplantation program. So we can't refuse. It may not be bridge to recovery. It may be bridge to transplant. So there was cross-infection. Now we have ECMO ICU as individual rooms. There is a separate 16-bedded ICU and each patient will have one room. So there is a nursing barrier. Of course, they will use complete barriers. They will wear a gown, mask, everything. And of course, all the other aseptic precautions are same. And other thing is, all these people are used to managing the ECMO. in the beginning, touching the three-way, all those things, so many aseptic precautions were not taken, but now all of them are well trained. And of course, in spite of all these things, we do see infections, sometimes MDR, all those things we do see, but they will respond to antibiotics. But problem is after 1 month, they keep on getting septic episodes. That is because the basic source of infection is from lungs. So unless you take out lung, the infection will not subside. So we had one interesting experience. One man, he was almost waiting for transplant for 70 days. And the day lung was available, he was in septic shock. So it was worsening. Then Dr. Bala said whether to do it or not. Then he said he has waited for so long, let us go ahead and do it. Surprisingly, after taking out the lung and with antibiotics, this infection subsided. He did well, in fact. He was almost a 62-year-old guy. He got discharged in 3 months' time.
What is the, yeah. So I think that's, you removed the source of infection. Just a question, sir. What is the survival of lung transplant patients? Maybe 1 year or 5 year survival in your center or in your experience?
See, 1 year or 5 year, we do not have this one.
Okay.
But we had done lung transplant for ILD and primary pulmonary hypertension. We have follow-up for 5 years, 6 years. They are all doing well.
Fantastic.
It's not 100%. I think I'll say around 70%, 60 to 70 to 80%. But in COVID, the mortality is maybe a little higher.
What we understand,
around 50-60%. But this is only 6 months to not 1 year follow, 6 months follow.
So what we understand that COVID is like a multi-system disorder. Questions from Kailash, you have any questions? Because I think we are running out of time. I'm not going to present the cases. We'll just like to conclude in next 5 minutes. Dr. Kailash?
No, sir. It was a very good discussion.
How is ECMO used in Italy? Very commonly, routinely used for, was it routinely used for COVID patients?
No, actually, sir, our hospital is not COVID dedicated.
So good. You have experience like me, zero experience in COVID patients. Dr. Dinesh, you want to comment on anything? Dr. Ajay?
Sir, I would like to ask Dr. Suresh, how is your experience regarding requirement of blood transfusions in patients with ECMO? Do they frequently requiring blood transfusion? And second, if they develop acute kidney injuries requiring renal replacement therapy, so whether you are preferring CRRTs or you are doing SLED for them, which one is being preferred at your center, please?
Yeah. Yes, regarding the blood transfusion, yes, in the beginning, 3-4 days, they may not require any blood transfusion because it's a percutaneous insertion, hardly any blood loss. But after 1 week, sometimes they do develop thrombocytopenia, sometimes bleeding, especially GI bleeding. So they do require sometimes blood transfusion. Regarding the second question, yes, they do develop sometimes AKI and we go for CRRT, not SLED or anything, because it's also what we have seen is if they are septic, by starting CRRT, in fact, all their cytokine levels will come down and they do better also.
Dr. Govind, Dr. Pavan? So I think, Dr. Govind, do you have any questions for sir?
It was very excellent talk. Just a small question from you and Dr. Buddha. The same question as you, same patient as you described, right in the emergency with the cardiogenic shock and the revival with the CPR. And there is a concept we call eCPR. So how do you select after CPR revival the patient, whether to put Impella or whether we should go with the ECMO device? How do we select patients?
So one thing is clear, in a patient with cardiogenic shock, some sort of mechanical circulatory support device is required if you cannot do a immediate revascularization. So let me tell you about the ideal situation. Ideal situation, such a patient should get an Impella and not an ECMO, because ECMO increases the afterload. You are sucking from the vein, you are pumping into the aorta. and also there can be hypoxia in the upper part of the body, and similarly there can be hypoxia in the coronary arteries, because the upper part of the circulation is non-oxygenated and lower part of the circulation is oxygenated. You can overcome that by doing, putting a balloon pump and various other parameters. But the ideal device for a cardiogenic shock is Impella. Now, if you have biventricular failure, let us say an inferior wall MI with RV MI and cardiogenic shock, probably it is a combination of VA ECMO for the RV and an Impella for the left ventricle. So,
yes. Is not yet there. Impella RP.
Impella RP is not yet approved by in India, sir. If there is a patient with RVMI, we would prefer a VA ECMO for a refractory RVMI, because you just need time for the RV to recover. So I think that was a very, very interesting discussion. I hope it was very useful. It was definitely useful for me. I've learned a lot of new things, and which I will try to implement in my practice. And I hope it was very useful for the audience. But let me thank all the faculties and all the speakers, especially Dr. Suresh Rao sir and Professor Dr. Rajiv Bagrata sir, who have taken time out from their busy schedule and have tried to educate us on this complex disease called cardiogenic shock syndrome. I would like to thank Ajay, Dr. Buddhaditya, Dr. Govind, Dr. Kailash, Ola from Italy, and Dr. Dinesh from Bikaner. So, before we close and before I say goodbye, I would like to have a closing remark from Professor Rajiv Bagrata sir for all the speakers. Sir, are you there, sir?
Yeah, I'm very much there.
Just a closing remark.
I could not have afforded to, leave the session in between. It was so interesting. And I should thank you for organizing and for taking all the pains to talk to everybody personally. And as Dr. Suresh Rao mentioned, that the flow of the topics was absolutely fantastic. The ball was set rolling in the way it should have been. And the conclusion has been as good as the starting point was. And I specifically thank Dr. Suresh Rao for educating all of us. And I just hope that we have more of such sessions. Thank you, everybody.
Hope to see you all in person in 2022 if there is no third wave and conditions are better. Yes. Thank you all, and good night, and have a good weekend. Thank you.
Thank you all.
Thank you.